Hello, everyone. Good morning. It's great to be here on Gay Health Forum Day. My name is Bill Foley, and you're all very welcome to the 18th Annual Gay Health Forum. I'm the Secretary of Gay Health Network, and I was part of the organising committee alongside colleagues Adam Shanley of HIV Network and Jay Doyle, Administration Manager with Gay Health Network. And this year, for the first time, the forum has been a collaboration between Gay Health Network and HIV Ireland. And tech support is supplied by GCN in the guise of Alice Lenihan. So thanks to all of them. We're particularly delighted to be finally here as the event had to be cancelled last year, obviously. And we're now back for GHN 21, which is the 18th annual forum. Hopefully next year we can return to a full day event and an in-live conference rather. So in the meantime, for today, we have a half-day session and it's a very packed program. I think for most of our services during COVID, it presented a lot of challenges to us, but also opportunities for new work and new ways of working. It's clear that many agencies continue to work at a very busy pace, and some of us even more busy than usual. In Gay Health Network, we had a particularly busy time. We developed new COVID-19 safer sex information campaigns alongside our key stakeholders, Sexual Health and Crisis Pregnancy Programme. We recruited 2 new posts during the period, and as a result have increased our social media messaging, developed new campaigns, and updated and expanded our website materials. And last month we produced our annual report, which is now available in full on our www.ghn website. We're currently finalizing our 5-year strategic plan, and we're hoping that will be produced now in the next month or so. So I know from contact with all of our GHN colleagues that they have also had a busy time, and highlights of some of those actions in the agencies will be presented in session 2, which focuses on community development programs. Section 3 is the 13th Noel Walsh Memorial Lecture Series. And Noel, for those of you who don't know, was a really lovely, engaging, charismatic HIV positive man who campaigned tirelessly for Gay Health Network before his tragic and untimely death. So this session will explore the migrant experience in Ireland, and this is particularly important now as we see rises in episodes of racism and so on, particularly and worryingly within the LGBT community itself. And the final session is taken up by Dr. Fiona Lyons, who's consultant in genitourinary medicine at St. James's Hospital and clinical director for STI services nationally, who will give a state of the STI nation address. Just during the presentations, you can ask a question or make a comment at any time, and we'll endeavor to get to all questions at the end of each session where there's a Q&A session. So it would be great if you could add your name and also your agency, if appropriate, to that question. For presenters, we will be interrupting your presentation briefly at the end to give you a 2-minute warning, as we're expecting it'll be tight on time today. But for now, we'll begin at the beginning. Session number 1 is given over to our colleagues in the statutory sector. And this builds on many years of fruitful collaboration work between Gay Health Network, the Department of Health, HSE and SHCPP. So to open the forum, I am delighted to introduce Minister for State for Public Health, Wellbeing and the National Drug Strategy. Minister Frank Fegan, TD, represents Sligo, Leitrim, North Roscommon, South Donegal, Dáil constituency. He is former chair of the Joint Oireachtas Good Friday Implementation Committee and a member of the British Irish Parliament Assembly. Here is the message from the Minister.
Ladies and gentlemen, a very good morning to you all. Thank you for your kind invitation to speak at today's event. I am aware that in previous years my predecessors have attended the annual Gay Health Forum, which unfortunately could not be held last year due to the COVID-19 pandemic. I did, however, have the opportunity to address the Gay Health Network in November of last year on the occasion of the 25th anniversary of the network, and I am delighted now to be able to address the forum this year. The various member organisations of the network, in partnership with the HSE, are playing a vital role in implementing our national sexual health strategy. This partnership has been more important than ever as we have had to adapt to the challenges of the pandemic. The onset of COVID-19 led to unprecedented interruptions to normal healthcare activity, with most services affected, including sexual health services. While we need to continue to be vigilant in our response to the virus, we have been able to lift many of the restrictions imposed to combat the pandemic, and it is very heartening to see our businesses, social gatherings, sports and other activities slowly begin to resume. I am of course aware that the disruption to sexual health services has been a source of great concern over the last year and a half. While services are still dealing with the effects of the restrictions, we have thankfully made some good progress in service provision. The Gay Men's Health Service reopened in January on a phased basis and in line with government and HSE guidelines. And with gradual increases in staffing and other additional resources, the GMHS has been able to incrementally expand the number of services offered during the course of 2021, and this process continues. The rollout of the National PrEP programme was a significant landmark in the implementation of the National Sexual Health Strategy 2015 to 2020, and despite COVID-19 restrictions, the National PrEP programme has continued to expand, with services continuing to see new and review existing PrEP service users. Many services adapted how they worked, delivering some care on a virtual platform. And services have been working hard to restore and increase service capacity throughout 2021, notwithstanding the challenges faced by the ongoing pandemic, the cyber attack on the health service, and most recently, a national early infectious syphilis outbreak. One of the most encouraging developments recently in service provision has been the success of the HSE's home STI testing pilot project in Dublin, Wicklow, Kildare, Cork and Kerry. My department was happy to support this throughout the Sláintecare Integration Fund, and we are currently in consultation with the HSE to explore avenues towards expanding this pilot. Looking to the future, you will be aware that my department has begun a review of the National Sexual Health Strategy. And during the summer, we held a number of consultation meetings with stakeholder groups, which proved to be very helpful in identifying the key concerns and priorities for the development of services. Some of you here today will have attended those meetings and made submissions to the review, and I want to take this opportunity to thank you for your input. Work on the development of the refresh strategy will continue in the months ahead, and I look forward to seeing the results, which will enable us to build on the progress already made. I know that you have made a full and diverse range of presentations during today's webinar, which I am sure will be a source of great interest and debate. And it only remains therefore for me to thank you all again and for your support, and enjoy the webinar. Thank you.
That's great, Minister. Thank you very much. It's great to hear that the expansion of services is continuing. It's much needed. As we all know, in relation to COVID, it was a very bad setback for STI services nationally. And so there was catch-up required and expansion required before COVID. So that presents additional challenges to future collaboration for the development of services nationally as we move forward out of COVID. Our next speaker now is Naomi Saffon, and Dr. Naomi Saffon is a specialist in public health medicine working on HIV and STIs with the Health Protection Surveillance Centre and the Department of Public Health East. So here is Naomi.
Thanks, Bill. I'll just share my screen now. Just let me know if that's not sharing. So morning, thanks for having me here. I'm just going to take you through the epidemiology of HIV and STIs predominantly over the last 2 years and focusing on the GBMSM group in Ireland. And just to note, I guess, just overall in general with the pandemic, we have seen a decrease in a lot of the STIs, apart with the exception of syphilis. But the pandemic, as well as having an effect on services, has also had effect on our data. So we don't have the same sort of level of data as we would have had previously. But I'll take you through what we do have available anyway. So firstly, just looking at HIV. So we can see this is just showing the rates and number of diagnoses in HIV since 2003. And you can see in 2019, there were 534 diagnoses of HIV, and that's a 2% increase on 2018. But then, as we saw in 2020, there, as with a lot of the STIs, there was a drop off in numbers, and there were 449 notifications in 2020. So that's a 16% decrease compared with the year before in 2019. So that just equates to a rate of 11.2 per 100,000 in 2019 and a rate of 9.4 per 100,000 population in 2020. The majority of notifications are still seen in males. So in 2019, 74% of the notifications were in males, so that's nearly 400 notifications. And then in last year, in 2020, 79% were in males, so it's just over 350 notifications. And when we look at age, you can see in 2019, the highest rates were seen, as in previous years, in the 25 to 29-year-old age group in males. There was a bit of a change last year, and the highest rates were then seen in the 30 to 34-year-olds, as opposed to the previous few years. Now, these are just showing notifications by probable route of transmission, and just to draw your attention to the bars on the chart are just showing the missing data there. So it's difficult to make to really make interpretations from this data, but where we do have the data available, we can see that MSM still accounted for most of the transmission, followed then by heterosexual transmission, and then a smaller proportion due to injecting drugs. Again, looking at notifications by region of birth, as was seen in previous years, the majority of cases were born abroad as versus born in Ireland. But again, the missing data really makes this difficult to interpret. Then when we look at the notifications of HIV by history of a previous positive, so people that had a known diagnosis before their diagnosis in Ireland, you can see that there was perhaps a slight decrease in the proportion that did not have a previous positive last year. So but looking at the missing data, it's hard to say whether that's a real thing or is it just that data is unknown. But we'll keep an eye on things, and we're hoping that this data will improve shortly. Then just to focus on syphilis. So as we knew, syphilis was increasing pre-pandemic. You can see up from 2016, the numbers of infectious syphilis cases were increasing. And then in 2019, there was actually a 54% increase compared with 2018. So 746 cases in 2019 versus 484 cases in 2018. Then in March of last year, with the onset of the pandemic, there was a big drop in the numbers, but they did start to increase again over the course of last year, and that trend's continued into 2021. So case numbers up to September this year have been 52% higher than the same time period last year, and 10% higher than the same time period in 2019. And as was mentioned, there was an early infectious syphilis outbreak declared in June, so work has been ongoing to look at this. Where we do know about mode of transmission, we know that GBMSM account for over 90% of the male cases. Again, obviously the missing data is still a factor, but it does look like they're still the majority group affected. And then moving on to trends in gonorrhea. So pre-pandemic, gonorrhea numbers were increasing. And in 2019, there were 17% more cases compared to 2018. So it's 2,812 cases compared with 2,402. However, there was a big decrease in March of last year, and cases have really remained low since then. And so if we look at cases this year to date, they're 47% lower than the same time period in 2019 and 15% lower than that time period last year. Males remain the most affected group. 84% of cases in 2019 were in males, and 87% were in males in last year. And where mode of transmission is known, the majority are GBMSM again. But also just to note, of course, the issues with the data there. Then just to talk about LGV. So looking at LGV, there was a 39% increase in LGV cases in 2019 compared with 2018. The numbers are still quite low, so 39 cases compared with 28. Notifications decreased in 2020, as with many of the other STIs, and they really remained low since then. And if we look at the numbers up to September this year and up to September last year, they're less than half that in the same time period in 2019. All cases of LGV to date in Ireland have been in males, and where mode of transmission is known, GBMSM has accounted for the majority of cases, and in fact all cases in the last 2 years. The majority of cases are HIV positive, where we do know about it, HIV status. As you can see in the last year, we don't have that data available for over half of the cases. But overall, 73% of the cases of LGV have been HIV positive. And then lastly, just to touch on sexually transmitted Dentariac infections. So these are gut infections which cause stomach cramps, diarrhea, sometimes vomiting, and they're transmitted via the fecal-oral route. And we see cases of sexually transmitted shigellosis among MSM, and they're important because they're often associated with antimicrobial resistance, and they really show the importance of promotion of hygiene messages before and after sex. So when we look at shigellosis in Ireland, it's not just confined to, it can affect any of the population, but it does affect adult males more than adult females and children, and 58% of the cases in 2019 and then 72% of the cases in 2020 were in adult males. Where we have the data available, and the majority of cases are due to GBMSM, so 67% of adult male cases were GBMSM transmission in 2019 and 74% of the adult male cases last year were due to GBMSM transmission. So just to summarize that, really, obviously, you can see the impact that COVID-19 has had on our data, as well as the STI services. We do know that syphilis rates are increasing, whereas the other STIs have not increased to the same extent. The males remain the most affected group for STIs and HIV, and where data are available, GBMSM accounts for the majority of transmission. Sexually transmitted enteric infections are an ongoing issue, and they just show the importance of sexual and proper condom use. And just for further information, you can visit sexualwellbeing.ie for more information on testing. And then hpsc.ie still publish their weekly reports, and there's some more detailed epidemiological reports available there too. And just to acknowledge everybody who has provided data for this update. Thank you.
Thank you very much, Naomi. That was a very interesting and insightful presentation there. Very worrying trends, obviously, with gay men and bi men scoring highly in relation to infection rates for both HIV, syphilis, and other STIs there. So to me, your presentation very much underscores the demand for a full expansion and restitution of STI services for gay and bi men over the country, since we're the ones most at risk and vulnerable to infections at this time. So that might be a focus for debate later. Our next speaker then is Caroline Hurley. And Caroline is a project manager with the Sexual Health and Crisis Pregnancy Programme. Caroline has worked as a project manager in the HSE Sexual Health and Crisis Pregnancy Programme for over 5 years, predominantly working on the clinical actions of the sexual health strategy. Caroline has a nursing background and a master's in public health and has worked in the area of sexual health and HIV, both at home and internationally, for the last 20 years. So here is Caroline.
Good morning. Thanks, Bill, for the introduction, and thank you for inviting me to speak today. I'm just going to share my screen. Now, so today I'm just going to give you an overview of our clinical team and some updates on PrEP, on our online home STI testing service, on the HPV vaccine, our HpV Fast Track Cities initiative, and our planned next phase of our HpV Stigma Campaign. So we're delighted after a few years break to have our clinical lead back. Professor Fiona Lyons has rejoined our team, so delighted to have her back with us. And Rachel Matrustri has joined our team since last December. So great to have a bigger team now than we had before, so lots to do. So to start with PrEP, as you know, we secured 5.4 million funding, annual funding from 2019 for staff resources and for PrEP medication. So PrEP is currently available in 13 public STI clinics, the most recent being Sligo and Letterkenny that have commenced their PrEP service, and 9 private services. So up to the end of June this year, 3,468 individuals have been registered for PrEP. So as you can see from the breakdown here in the table, the people continue to be registered and commenced on PrEP over the last year, especially, due to in relation to the COVID-related service restrictions that we have seen. So, people have continued to commence on PrEP, which has been really great. So our home STI testing pilot, we secured funding last year from Sláinte Care and with co-funding from ourselves to pilot a home STI testing service that was integrated with public STI clinics in Ireland. So we partnered with online provider SH24, and the pilot was run in the counties of Dublin, Cork and Kerry. Last year, the online platform was established and the service went live in January of this year and ran until the end of May. Over the pilot service delivery period, a total of 13,749 STI test kits were ordered. Almost 5,000 test kits were ordered in the first 24 hours, which resulted in a temporary pause to the service, which then did resume and continued on until the end of May. During this time, 734 STIs were diagnosed, which is an 8% reactive rate, which was fantastic to see. Really interesting outcome from the pilot was that 57% of service users, of people who use the pilot, had never accessed a sexual health service before. So it really showed that this service is reaching people who may not attend a clinic. So really a fantastic outcome of our pilot. And the pilot also showed that 99.4% of users rated the service either a 4 or a 5 out of 5. So the evaluation of the pilot is currently being completed. So that report should be out in the coming months. And a business case has been submitted in order to our planned, which we would like to expand nationally. So we're seeking funding for that. So currently the home STI testing service has been continued. This is a temporary measure and is supporting the syphilis outbreak. Home STI testing is available free of charge at the moment to individuals from the age of 17 with an address in the following counties. So the initial pilot counties of Dublin, Cork and Kerry, which were expanded in August to Kildare and Wicklow. Since last Friday, the North East has come on board with Cavan, Louth, Meath and Monaghan, testing now available there. And we're hoping then by the end of October that the home testing will also be available in the counties of Galway, Mayo, Roscommon, Laois and Offaly. So for more information, if you want to order an STI test, please visit sh24.ie. So the HPV vaccine, we've continued to provide the HPV vaccine in line with NIAC recommendations to men and women living with HIV up to and including 26 years of age, and to GB-MSM, including GB-MSM living with HIV up to and including 45 years of age. And since this year, we've moved from Gardasil 4 to Gardasil 9, although there does continue to be some global stock issues, but the programme has continued. As you can see from the table below, 2019 obviously was our best year, with well over 3,000 people being commenced on the HPV vaccine, which is a course of 3 doses. Obviously, there was a drop last year due to COVID and the service restrictions, and hopefully this will pick back up again this year. So our HIV Fast Track Cities initiative, our 4 main cities, Dublin, Cork, Galway and Limerick, signed up to the initiative in 2019. Again, some delays last year due to COVID, but our 4 city steering groups have now been established, and we currently have a HIV scoping study underway. And the scoping study will provide the evidence base for the establishment of the HIV Fast Track Cities initiative across Ireland. It will inform the work of the steering groups and the development of city-level epidemiological profiles and implementation plans. And through the study, we will engage with all the relevant HIV stakeholders across a broad range of sectors to collect data and obtain their insights into the future service requirements. As many of you will have seen, we launched just before COVID, we got in there just in time, a national stigma campaign in early 2020. And the focus of this campaign was on the U=U message, that effective treatment means that you can't pass HIV on to partners. This campaign was a collaboration between ourselves and the community. And the plan now is to extend this campaign, do an extended campaign with GB-MSM. It was planned for this year, again, just between COVID and the cyber attack. There's been delays, but the plan is for the campaign to be launched in 2022. But a steering group has already been established and we'll meet later this year, and that work will commence. So I'd like to just acknowledge the great work of the MSM Health Committee. And as you can see from the list here, we have a very comprehensive group of committee members. Many of these members have been involved in the syphilis outbreak control team over the last couple of months. And that has been a lot of the focus of our work, but the committee is due now to meet again in early November. So thanks again for having me to speak today.
That's great, Caroline. Thank you very much for that. Lots of very positive news and programs continuing there. We do have time now for questions. So if you do want to ask a question, do put it in, and we'll try and get the panelists to answer them there. I suppose it occurs to me there, just in relation to the stats and the cyber attack there, I'm wondering, is there a possibility of recovering data so that those statistical informations can be improved on in relation to both your presentations? I wonder, Naomi and Caroline, if you could both maybe answer that.
Yeah, so I guess it's not just the cyber attack that has affected our data. So a lot of our data relies on the STI clinics and GPs as well, in some cases returning some of that data to the departments of public health, and then there's workload within the departments of public health to get that data into all of our systems. So we're working on trying to chase down what we can and get up the data into our system where it's possible, but it just takes a bit of time because understandably everybody has been pulled to COVID. So it's just really chasing that backlog, as well as then making sure that we've got the data coming in going forwards, because obviously things are kind of picking back up again, so that we don't leave a bigger gap. But we're hopeful that in the next, hopefully actually in the next few weeks, that we will have some better data available.
Okay, thank you. Caroline, do you have anything to add there?
Yeah, I mean, again, obviously there's been a drop in numbers, as you can see from the slides there, over the last year with COVID. But at least, the data is there. That is, there's lower numbers attended many services in the last year. For example, the HPV stats that you've seen there. For PrEP, the number of people who did attend did continue. So that data, we have that data. I suppose our challenge has been, the capacity of services to engage on, looking into the service level data in more detail. But because we can get the top level data from PCRS, which is the reimbursement service for PrEP, so our data on the numbers is accurate. It is just, I suppose there has been some delays in that the service level engagement and collecting additional data, which might be of use, but that's.
And it was great to hear that the PrEP is continuing, albeit at maybe rates that might not otherwise have been, might have been higher if COVID hadn't been around. But I presume the data around the effect of people's use of PrEP and the rising HIV rates isn't going to be available for some time.
Yeah, and then that's linked with, again, with public health in relation to the collecting the data. But, we know that in relation to the numbers of new diagnoses of HIV, it is lower. But again, a lot of work still has to be done in relation to understanding the current trends. There just has been, just with the year that's in it, from a public health perspective, Naomi, you might say more to that. It's difficult to ascertain the causal factors for different things.
Exactly, and I think in terms of HIV, we really need to get, because we have just to explain with our data, we have the basic data that comes in as we have the cases, we have the gender, we have the age, but it's that further information, that further level that is important to be able to really drill down into it, and that's the bit that we're missing and we need to work on. And of course, with with HIV especially, there's been changes in migration, and that has an impact on our HIV diagnoses, and we really don't have a handle at the moment on the extent to that. So that's just an important thing to note, as well as the changes. It does look like there has been a bit of a change in the age pattern of diagnoses. So that's something we're going to look into further. But as I say, it's really trying to get that data back up, and understandably things are getting back a bit more to normal society wise, but the pressures on public health are still there. So it's not, COVID has not gone away from that side of things.
Okay. We have some questions from the participants here now. So Elsa Spindler is just asking, I've just heard that the GUM clinic in Cork is not accepting new PrEP clients, and this is apparently because of a shortage of resources. When will we get a properly funded service?
Yeah, I think, that's the key thing there to say is that, the services have been working really hard, especially over the last year with all of the COVID and with COVID and the impact of COVID on the services, to deliver a service. In relation to, some of these challenges, I think Fiona will speak to it a little bit later on. Fiona's going to come in now and respond to this issue. It's probably easier to do it now rather than later.
Very good.
Sorry, playing musical chairs and masks on and off. Hi, I'm Fiona Lyons. Hi, Bill. It's nice to see you, Naomi. Alison, I think the challenge in Cork is a local issue, and there is a difference between allocation of funding and allocation of resources. So funding has been allocated. So I would really encourage you to agitate locally around ensuring that the funding that's been allocated is actually put into resources to allow the PrEP service. It was a very difficult decision for the clinic to make around not taking on more patients, but they have to provide a safe service. Funding was allocated, but not all the resources have been put in place. So please agitate about that locally within the Cork area to ensure that the service is reopened.
Okay, thank you very much, Fiona. Just another question there in relation to PrEP access from John Gilmore. do we have any data on waiting lists for PrEP access, and is this data being collected?
Okay. Hi, John. Thanks. Yeah, we did an engagement piece with services a couple of months ago, looking to see what waiting lists were there. At the time, most services had actually worked through their waiting lists post COVID, the COVID crisis, there are still one or two services now that are building waiting lists again, and that's that balancing act between being able to see new patients and the ongoing appointments in services. Some services had issues with a lot of people not turning up for their appointments. So these issues are being addressed as well, and making sure that available slots are being put to best use. So there is, so again, it's not something that we routinely keep, but we would engage with services on an ongoing basis to touch base and see where things are at, as well as looking at how we can improve availability.
Okay, there have been some kind of reports as well on the home testing kind of process. It's obviously a high demand service, Caroline, and is there any indication of whether the demand is being met, or how much of the demand is being met, and what further resources might be put into that?
Yeah, so for the current counties where where the home testing service is available, the service is capped, so there's a daily cap in place, and that's really just to avoid issues like on day one where 5,000 tests were ordered overnight, because those who have a reactive result are signposted into public STI services. And it's a matter of maintaining capacity. And again, the service is temporary at the moment, so the number of tests available is limited. But then this also means that so the beginning of the service, the daily caps were being reached all the time. So the tests were already gone by 9 o'clock in the morning. It then moved to 12 o'clock. It then moved to 8 o'clock in the evening. So even now for Dublin, the daily cap isn't being reached. So it does show that there was a very big demand at the beginning, but it has stabilized, and it shows, you always have a big demand when people think something is temporary. People were trying to order 2 tests, keeping one for later, and this is understandable. And once a service becomes a routine service, that sense of urgency then goes away, and it just means that, you will have people not just ordering a test because they've seen it opportunistically online, but they will then order a test if they're actually seeking a test. And again, so once this service does become a normal service and it becomes routine, then we will turn then to promoting and making people more aware of the service, for people who don't know that they can order a test, and to promote this, because we do know that for many people, they're nervous about going to a clinic at the time required in order to take time off work to attend a clinic. So there is massive demand, and as we see now again, as the new counties are opening, there's that initial kind of spike in the new counties as that interest is there, but it will normalize over time. And we think, especially, hopefully next year, should the service be funded for national rollout, once it is available everywhere. And we know, we don't have public STI clinics in every county, so it'll be really fantastic, especially for those counties that are underserved in relation to services. And this will also support the capacity of the PrEP clinics, because for people who are on PrEP and are maybe having a virtual appointment online, they can order the tests online as opposed to having to go into a service as well. So all of this really will just support that more broader comprehensive service that we're looking towards.
That's great. Thank you very much, Caroline, for that. We probably look forward to working together on campaigns of information and dissemination about that in the future. We've run out of time at that, so thank you both very much for those presentations and for your answering of the questions there. It was really interesting session. Thank you very much. I hope both of you are able to join us for the rest of the morning, and to obviously log out now from the StreamYard thing and log in again on Facebook or YouTube. I know that some people be having maybe difficulty getting in. Some presenters have been having difficulty getting into the StreamYard site, so we should be able to try again at this point in time as we move to the next session. And for that, I'd like to hand over to my colleague, Jason Doyle at Gay Health Network. Thank you very much.
Good morning. Thanks, Bill. My name is Jason. I'm the admin manager for Gay Health Network, and I'm obviously excited to be participating in this next session. As always, if viewers have any questions for our upcoming presenters, please do feel free to submit by way of chat. They'll be gathered and presented either at the end of the session or at the end of the forum itself. So without any further waiting, I'll introduce our next presenter. So I have the pleasure of working alongside Porg, who joined GHN as the communications director in June of 2020. And Porg also manages the man-to-man.ie program, which is run in partnership with the HSE and supported by the SHCPP. So for now, I'd like to hand over to Porg, who'll be discussing online campaigns and messaging.
Hi, good morning, everyone. Thanks, Bill, and thanks, Jason, for that. I'm just going to share the screen and window. Of course, I'm at the end. Okay, hi. So I'm the communications director with Gay Health Network, and we run man-to-man.ie together with the HSE and Sexual Wellbeing. So we work closely with the Sexual Health and Crisis Pregnancy Programme and the HSE on putting out campaigns, sexual health campaigns across social media and various posters. And here we go. So how we reach our audience. First way we do this is through the Man-to-Man website, and then through social media. We have a Grindr partnership. We use digital displays. There's advertisement and poster promotions, pride events and cinematic displays, and then we have posters up, thankfully again just started in washrooms, and there's also the Google search function, and of course we work regularly with GCN magazine to get important messages out. So I began last year, I suppose it was during the pandemic, and the first thing we really needed to do was update the website, and working with the Sexual Health and Crisis Pregnancy Programme, we developed COVID-19 guidelines, just harm reduction for people who were having sex during COVID. And we also then, during the year, this year, we developed mental health pages and sexual consent pages as well. And we've also been constantly updating the testing and support pages and constantly updating the alcohol and drug section, which is an everlasting job. And all these changes are always going to be translated into French, Portuguese, and Spanish as well. So just to have a quick look at our website, last year we had 95,000 page views for 49,000 users. And like the top page last year is what is HIV, and you can see there number 4 COVID-19 came in, and that was through sort of promotion of messaging when the pages came out. This year users so far 44,556, and you can see there that number 2 syphilis has been one of the highest pages. It is the highest pages apart from the homepage. That was through the promotion during the summer because of the outbreak. And there you have number 3 testing and support, and there 4 condoms and lube. So the messaging in 2020 last year. So when I joined, we were in the middle of the pandemic. So the sort of messaging we had was initially just the sex and COVID, what's happening now, sort of use a condom, and also to advise people that there is, even though there was restrictions, that there was testing available if you had symptoms. So I mean, the services were severely restricted. Earlier on in the year, we had the Get Your Bits Out for the Lads, which was a great campaign, and hopefully we can start to do that again once things open up. And also with PrEP, the PrEP had really just come on board, and then the pandemic happened, and so access has been curtailed. But as we heard earlier, there have been new people getting PrEP during the year and during the pandemic. And also PEP, it was also to put out important messages about PEP, which is another prevention for HIV if it's taken within 72 hours. So this year, the sort of messaging, just have a quick look. We did some work on sexual consent, which we put out in September. We did some work on mental health, answering sort of feedback from the community. So we'd have that lighten the load, and just know the facts as well around alcohol and drugs, just to try and reduce the harms really, and let people know or make them aware that there is, there's pages there with advice and links to other sort of good stuff as well in terms of the Empower's chemsex, which was another welcome addition this year. And then of course there was syphilis, which has been a big campaign during the last few months. So yeah, here this one that know the facts. Chemsex, and the designer was Pete Reddy, and there it is appearing in GCN magazine alongside the mental health, the lighten the load as well. We put a lot of work into these. We worked with the subgroup, so we had various people from Sexual Health Centre in Cork and Gosh and Limerick, and these were really, there was a lot of thought and a lot of work put into this over the year between the pages and this, and just to thank them for all the work that they did as well, especially Billy and Limerick. And so here, yeah, this was designed by Pete Reddy as well. And here's some consent creative, and that was designed by Kai Fabro. And then here's syphilis, sort of one of the main campaigns of the last 3 or 4 months, and the designer here is Maurice Farrell, and he did a great job. I think they're very striking. And another thing we did as well during the year was we had these 2 short films with sexual health professionals. So we went down and we spoke to people from Gosh, Sexual Health Centre in Cork, and Empower. One was about sexual health and the other was about mental health, and I suppose was looking at sexual health not just as the absence of disease, but also like mental and social well-being, that we are comfortable in our sexuality and our gender identity. So those 2 videos are available to look at on YouTube at Man to Man Ireland, and also there was a British version played at the Gays Film Festival, and they were made for for Virtual Pride in 2021. So if you haven't checked them out, do. The people, like the guys, are great. Okay, so just looking at the social media messaging, Facebook and Instagram are very important for us to reach our audiences. So this is from 2020, from last year. So our reach was 326,069 with 587,000 impressions. So, and our messages again were like COVID, if you're tested, go and get, if you have symptoms, go and get tested, use condoms, U=U, and PEP. And so this year so far, we've reached 314,000 people and already have had 1.2 million impressions. I guess, again, syphilis would have had a big impact on this. We would have put a lot of resources into that. So looking over the last 2 years, and these are messages now that we've added together. So there's been a constant flow of messages. So syphilis has reached 153,000 people. Symptoms get tested 142,000. U=U 59k. Mind Your Bottom, which free condoms was 43k. Sex and COVID 36.9k. PEP 32 and PrEP 26. And Lighten the Load 22.8k. So I know Facebook has a lot, coming under a lot of criticism, and certainly it's warranted and deserved, but it has, and for many small businesses or organizations, it does serve an important function, and it helps us reach audiences. So looking at Twitter, so reaches and impressions last year was 310,000, and then this year like 342,000. So Twitter is a great way for sharing information. For we can tag partner organizations in the Gay Health Network and just support each other. And so then we have a Grindr partnership as well, which has run since September 2020, and it's targeted messaging to our core audiences. And as of April this year, we have 2 messages per month, and this partnership will continue to December, and then we'll review it. But it was good in the meantime because of COVID and venues being closed. We could target people online, and online became very important actually. And just to say, we have 13,000 sessions have been created on the Man to Man website through our messaging, which have included messaging on taking G or preventing HIV, or if you're having chemsex, and they were the most popular. So the drugs and alcohol one, I suppose they were informative, and I think it's like the syphilis one as well. So it's almost like clickbaity stuff. If you say 7 things you need to know or 5 things you should know, people will tend to be drawn to them. And now Grindr are allowing banner ads as well, so that's another option that we have and we will be using. So there are some examples of the messages. G Reduce the Risk was probably the highest one we had, with 5,026 opening the message, and then 1,500 going through, so that definitely was the highest. So other social and hookup sites I've used have been Scruff and Recon. Snapchat has, they were average, okay to get results, but Snapchat was quite good, and it's something we will be pursuing, and obviously even tailoring the messages and targeting them and sort of making them funky so that people will open them. But Snapchat is definitely a very good way of accessing an audience. And so we also have digital displays. Just from last year, you can see we had 1.5 million impressions and 3.5 thousand clicks throughs. So that Sex and COVID-19 was the best performing creative, followed by Mind Your Bottom, which was, you know, you'd got, if you clicked it, you'd get access to free condoms or information as to where you could find free condoms. So the digital displays are continuing at the moment, and currently we have Syphilis is on the rise out there. So these appear in the Irish Times, the Irish Mirror, Distilled Media, JMG, DMG, and the Independent.ie. And it really is a great way of reaching audiences. And so if we make arresting visuals and have a small, key, snappy message, the people do respond. It's great. We just saw, I got a tweet the other day, I saw a tweet from ImageZoo. So we have posters up in venues again around the country, in Kilkenny, Waterford, Cork, Galway, at LGBT friendly social venues. So they are gay and straight venues, LGBT friendly, so not exclusively gay, and you can see them there. So also we have Google Search, which is a paid facility the HSE provided, and this is from last year, we had 492,000 impressions, and the highest performing one was HIV with a click-through rate of 4%. So, and also GCN magazine. So throughout the year last year, unfortunately, you know, there were restrictions. So but anytime there was a publication, we always had a couple of ads in there, so we doubled up. And even this year as well, we had a partnership with them during August to spread the word on the syphilis campaign. So they put out a scheduled month of tweets and Facebook posts and Instagram, and also an article in the magazine with a Q&A with Dr. Naomi, who we met earlier, which was very informative. And so what's next? Looking at campaigns that we may do, like prevention is always going to happen, vaccines, PrEP, condoms. And I really can't wait for the pandemic to be over so we can really push these, get your bits out for the lab. It will be great the day when it comes that we can say, you know, tell everyone to get their backsides into the clinics again to get tested. As we heard earlier from Caroline, we're going to do the HIV Stigma and U=U next year. Looking forward to that in early 22. But also then, there will always be like messaging on drugs and alcohol harm reduction. The syphilis will probably continue for a while, but also sexual health and well-being and mental health and well-being, and looking at partnerships with people where we share sort of common goals. So just a last little reflection, our communication should be sex positive and holistic, embracing the WHO's definition, sexual health as a state of emotional, mental and social well-being in relation to sexuality. So it's like sexuality is not just for when you have you know, an STR or a symptom. It's something we should be conscious of every day as part of our overall health. We want to invite people to be part of the conversation, to engage real people to tell stories, and work with influential people, artists, creatives in the community to help spread the message and, you know, spread the message. We want to reflect the diversity of the community and also embrace new technologies and mediums to reach new and harder to reach audiences. So that's our hope for the future. Thank you. Thanks.
That's great. Thanks, Pádraig. It's great to see there is a consistency in growth and access in sexual health and also mental health information. And with a mention of 1.5 million impressions and 315,000 click impressions, it's equally fantastic, and a continued focus and importance to push alongside obviously access to sexual health services. There's a growth in public awareness on U=U. So thanks, Pádraig. Our next speaker really needs not much of an introduction, and he was recently renamed Cheesecake by none other than Panty Bliss. Adam Shanley is the manager of the Empower program at HIV Ireland. Adam is committed to understanding the sexual health and well-being of GB MSM. He works closely with his peers at the Empower team and in the community to devise responses and resources that help gay and bisexual men to have a fun, pleasurable, and importantly, a healthy sex life. So part of that work is to create services which make testing for HIV as easy as possible. And today, Adam will talk to us about HIV self-testing is an important part of achieving that goal.
Hi, Jason. Good morning, everybody. Thanks for that introduction. I'm just going to go ahead and share my screen. Hopefully you can all see that now. Yeah, it's great to be back at the Gay Health Forum again. It's great to be sharing all of the information that has come so far, and I'm looking forward to listening to the presentations for the rest of the morning. I'm going to speak to you about our HIV self-test service at HIV Ireland that we've entitled Empower Yourself. Just to give you a quick background as to what prompted us to want to develop a HIV self-test service. Obviously, as Naomi had pointed out earlier on in her presentation, HIV transmissions continue to rise. It's estimated that about 929 people in Ireland are living with undiagnosed HIV, and GBMSM continue to be disproportionately affected by HIV. And of all of the newly diagnosed individuals, almost half of those HIV diagnoses are diagnosed late. And HIV testing is really a key tool in kind of, I guess, stemming new HIV transmissions. Obviously, people that get tested and know their HIV status and are tested positive can be linked to treatment. And as we know, people living with HIV that are on effective treatment cannot pass on HIV. And that one of the kind of key goals to that is stemming onward transmission. But to make testing people that are, I guess, have an ongoing vulnerability to acquiring HIV, regular and repeat testing is really, really important. And to get into that kind of flow of regular and repeat testing, choice and an ease of access is really important. And so that's kind of a cornerstone of what we wanted to do with HIV self-testing, is add another choice and ensuring that there is a number of different low threshold approaches to accessing HIV testing. One of the other kind of goals, I guess, of why we wanted to start HIV self-testing was because of the impact of COVID-19. Obviously, as has been mentioned so far, there was a significant impact on services, with many being restricted or closed entirely during the height of the pandemic. But during that time, there was a continued need for routine testing. And so we saw that, self-testing might be an opportunity to make that happen. So the self-test pilot itself, why do self-testing? I suppose it's largely regarded as a recommended approach. WHO has posited that, but also, we look to our closest neighbours in the UK, across Europe and across the world. Self-testing has really kind of taken off and is being considered acceptable. We wanted to understand whether or not that acceptability transferred into the Irish context. And as I said, it was an opportunity also to offer continuity in terms of access to HIV testing during the pandemic. Empower focuses specifically on the needs of GBMSM, but again, with the backdrop of the pandemic, we wanted to make sure that this service would be available to all, particularly because of the limited access to services. So the service was, during this pilot, made available to everybody. But when we were looking at advertising, we did target ads towards the GBMSM community. And how did we get this off? We wouldn't have been able to do it without a donation from Viatris, which is the new name for Mylan. They were very thankful to them that they donated 2,000 HIV self-test kits to us, and Gilead made a donation towards postage and packaging. So with the setup, we created a bespoke website, a portal that sits on the HIV Ireland website. And this allowed us to make sure that we were able to verify orders, to make sure that anybody that was placing an order, that they would only get one order, and that the order was a true verifiable order. We did that through one-time codes. So you'd put in your mobile number and you get sent out a PIN, and you'd verify that through the website, similar to what you know we're all subject to now when we're buying things online. We also use the website portal to be able to collect data. So on ordering, we would collect non-identifiable demographic data. Then we'd also collect the delivery data. Both of those data sets were separate. They weren't stored together. And once the order was sent for delivery, that data was deleted. The evaluation data, then 2 weeks after delivery of the order itself, because people have given their mobile number, we've asked for permission that 2 weeks after delivery that we could send them a text with a link to be able to fill out an evaluation survey. The website also gives us a full back end where we're able to process and fulfill all of the orders, so we know at what stage what each order is at. You know, if it's a recently received order, if it's been processed and sent, and also where we are in terms of the survey data. We wanted to make sure that we had a really strong support structure around the self-test service itself. So we make the Empower team leads out on all of this work, specifically also around the support that we make available. So we're available before, during, and after an order, during a test, after the test, obviously, and if anybody needs to be referred in for confirmatory testing, or just to know more about what they can do now. So if it's a negative result, how to stay negative. We have the support available through phone, through email, WhatsApp, and Zoom. Again, we wanted to make it as accessible as possible, and so we were also available 9 a.m. to 9 p.m. Monday to Saturday. So this is the test kit that we used. It's the Autotest VIH. It's a 15-minute finger prick test. It's IgG antibody only, so it does have that longer window period, and we kind of make that very clear. All of the information, including the HIV Ireland information, is actually printed on the box itself. We worked with the provider to make that happen, and the insert has all of our information too. But we also, in the package, have an additional flyer insert with info on what to do if it is a reactive result, the support that's available, how to get in touch with us, information about treatment, information about you equals you, information about your prevention options and how to access PrEP, PEP, condoms, etc. So we made sure that it was not only an opportunity for people to get a test for HIV, but also to fill in any knowledge gaps that might be there. So we launched the service on the 3rd of November last year. The campaign Empower Yourself is what we went out with. The kind of key messages there were to look at, I guess, positing how knowing your HIV status is a very empowering action to do. And also that this type of technology allows comfort. You're able to test in the comfort of your own home at a time that suits you. And some of the other elements that we pushed along with the campaign was that it's obviously that we're making this available across the Republic of Ireland, and that there would be no charge in using the service. So when we launched, social media was our kind of major driver. We had huge organic traffic. One post in the first week got over 162,000 impressions. And off the back of that huge organic traffic, we actually discontinued paid advertising, and organic was working so well through Instagram, through Facebook, and also through word of mouth as well. We had some unprompted kind of influencer moments where we had people actually doing the test on their Instagram stories and sharing it and talking about it. So it really kind of had a snowball effect in that way. And that really, affected demand. We, as I said, had a donation of 2,000 test kits. We naively, I guess, thought that might last us a couple of months. 2,000 test kits were all ordered within the first 13 days, and so we had to close new orders. And we made sure that we delivered them in a staggered approach, so that we had the capacity not only to get them out, but also to be able to take those support calls and make sure that, you know, if we weren't going to be overloaded with phone calls or contact, and so that everybody got the attention that they needed and deserved. So as I said, about 2 weeks after delivery, each person would get a text message with a link to a feedback survey. And I'm just going to give you some kind of top level figures that we received back from that. So we had, of all of the 2,000 tests that we got out there, we had 5 reactive results. 4 of those results came through directly from our support channels, and 1 was identified through the evaluation form, and we followed up with that person. The asterisk I have there is basically, you know, this is self-reported data. There's 5 reactive results that we know of. It is likely that there are more reactive results, and the people that received those results may have went directly to their doctors or to a sexual health service and circumvented the support that was available through us. And obviously that's their prerogative. So that may be a higher number than 5. The breakdown in terms of the demographic, just really quickly, 2/3 of users were identified as cis men, but we did have a number of non-binary and transgender people who access the service too. Again, the vast majority, 61%, identified as GBMSM. Of all of those who used the service and fed back to us, 31% had never tested for HIV before. So that's not an insignificant number. It's in and around, you know, the 600 or so mark of people who have never tested before. So similar to what Caroline is saying, I think it's proof that this type of, you know, home testing is definitely accessing a group of people who may have been foregoing testing before for a number of different reasons, in terms of the other services and ways to get tested. And so that, I think, in itself is a really important outcome of the pilot. With some of the feedback, so 81% said they found it really easy to use.
Hi, Adam. Sorry to interrupt there. Just 2 minutes.
Okay, I'm nearly there. Thanks, Jason. 84% rated the support available to be excellent or very good. Again, 84% would use the service again. 75% would prefer HIV self-testing over other testing services, and I think that probably links with the one of the last points there about not having tested before. And 85% would recommend the use of the self-test to others. So just I'll finish a little bit on some feedback. So generally, you know, the feedback was overwhelmingly positive, and a lot of what people were saying was, you know, that they've had maybe difficult situations in terms of accessing services before, you know, the struggle of the pandemic, and overall being kind of very happy with this type of service going forward. So very quickly, just the lessons that we've learned. We have changed the test kit that we use. That's partly because of cost, but also because of the test kits that we have previously were using were quite bulky. The ones that we use now are very slim. They're like a DVD test kit or like a DVD case. So it's much easier to get through the postal system. It's cheaper. We added more information based on feedback. We added more information about what to do with a reactive result. The breakdown of the amount of people where English wasn't their first language prompted us to have more information in Brazilian Portuguese. We have limited availability to every week now. The service has moved past pilot, and we're keeping it going. With limited availability to weekly instead of having one big rush. The service is now currently available to GBMSM only, but there will be plans to make it available to other key populations as well through Hpv Ireland. So I just want a special thanks to SHCPP, who continue to fund the Empower programme and have supported this service as well. Dublin Pride, who have given us some funding, as well as Gilead, and Titan Digital, who have made that wonderful website for us too. So thanks for listening, and sorry for keeping you a bit too long, and hopefully there's some questions near the end. Thank you.
Thanks, Adam. I guess with the backdrop of the pandemic, self-testing is now proving there is a continued need to help alleviate barriers people might face for those who don't have access to face-to-face testing venues, and the successes in no small part down to Adam Davey and the team at Hpv Ireland, providing the obvious invaluable support before, during, and or after at-home self-testing. So thanks, Adam. Our next presenter up is Phil Corcoran at the Sexual Health Centre in Cork. And Phil will be presenting and having a chat about LGBT plus public sex environment and access to services. So I'll hand you over to Phil.
Perfect. Is my screen sharing?
Yeah. Nothing showing yet.
Yeah. Of our services here at the Sexual Health Centre, we provide rapid HIV testing. We provide support for people experiencing a crisis pregnancy. So we have free counselling available. I want to make a decision on that pregnancy, and also for people. And also we have a sex worker support program here. We also provide sexual health workshops. We provide support to a number of different community groups. We provide training to professionals. We provide free condoms to anybody that needs them. During the lockdown, the first lockdown, March and July. So within that time, we had to get very creative. We're not, as many of us aren't, we're not the kind of, so a lot of our support and counselling services moved online or over phone, and we also set up a for our condoms. So for many months, I had a kitchen full of boxes of condoms, which went out. So we during that time we were closed for those 4 months or so. Service operating. So we've been back in the office since July of 2020. And recommence shortly after that. You'll be hearing from Conrad later this morning, who's our community, and we also operate a helpline Monday to Friday. So in my role as a senior health promotion, I oversee our rapid HIV testing program, and that would include the training of staff and volunteers. I also provide training to professionals, and right now.
Hi Phil, sorry, we're just having some connection issues. I'm not too sure if it's maybe connection issues on your side, so we might just pause on your presentation if that's okay. Move to the next. We'll see if there's an issue on our end, and then we can add you in after the next presentation if that's fine. Okay, thanks, Phil. So next up is an organization I have no doubt many people are familiar with, which is the Switchboard. The Switchboard was founded in 1974 and is Ireland's longest continuously running LGBTQIA organization. So for 47 years, it has provided a confidential listening and signposting service to the community and its friends. And here to speak about sexual health related calls are Eamonn, Reddington and Christopher O'Brien. So Eamonn's been a volunteer with the Switchboard since 2018, and in October of last year took over as director. Chris began volunteering in November of last year and is serving as community secretary since January. At the AGM earlier this month, Eamonn was re-elected as director and elected as CEO, and Chris was re-elected as company director and as COO of the organization. So without any further, I'll hand you over to Eamonn and Chris, and they're jointly going to talk about sexual health related calls to the Switchboard.
Good morning, and thank you very much, Jason and Alice. So Chris is going to share his screen, if that's okay.
Yeah, grabbing it now. Can you all see that?
Yeah. Perfect. Okay, so just yeah, so we're just talking about the time period since October last year in which we saw an increase in the total number of calls related to sexual health. So, yeah. So over the last year, a few of the things that we've done in the Switchboard are we rebranded from Gay Switchboard Ireland to the Switchboard to make the service more accessible to members of the community in general. Wednesday nights are specifically our men's night and the night that we deal with sexual health issues. So last year we've seen a massive rise in the number of calls related to sexual health. A lot of those calls, some of the things that come up are, like during COVID, whatever, a lot of confusion about sexual health services, obviously, and how to access them. People engaging in, hookups or going to sex parties. There's been a marked increase in calls from people in that category. A really big increase from men in heterosexual relationships who are experimenting with MSM or calls from older men where there is sexual contact taking place. Younger men, this would be kind of mainly, again, with confusion about accessing sexual health services, and calls about HIV, PrEP, and PEP. So over the last year, we've had over 1,300 calls to the helpline. Of those 1,300 calls, approximately 30% were specifically sexual health related. So that means like people calling, and the primary purpose of the call has, either been a sexual health related question, or they have brought up a sexual health related question. However, there's an additional 20% of calls that would have aspects related to sexual health, where the person themselves may not have brought that up, but it kind of becomes apparent later on in the call. The sexual health calls, where the primary purpose of the call is sexual health, predominantly from younger people who have questions about PrEP and PEP, or from men who are having hookups or attending sex parties and are concerned about STIs or HIV. Of the sexual health related calls where that has not been the primary purpose of the call, married men or men in heterosexual relationships form a very large part of that group. People who are having sex with men, so men who are having sex with men, and who have not considered sexual health issues at all. So this becomes apparent in the call. It's a very, very common pattern where they're still having a relationship with their wife, or, they're trying to still have a sexual relationship with their wife, having had sex with other men without even thinking about the sexual health aspects. So this involves, really trying to very gently bring in some education about the health risks and how to protect themselves and to protect other people that they're having sex with. The second group here, where are older men who might be having sexual contact with other men and who haven't considered sexual health issues, or more commonly, they don't even think that sexual health is related to them in some way, if they haven't actually made that mental connection, or they feel that they're too old to go and get tested. They just feel it's irrelevant. So trying to talk to somebody, in this situation is very difficult. There's huge resistance to the idea of getting tested at all. So.
All right, so I'm just going to quickly just give you 2 examples of the kind of stuff we get. So we had a call back in August, and it was a man called. He was showing symptoms of an STI, but he had trouble finding any local STI clinics in the area. So his plan was to travel down to Dublin and get tested, but his internet was down, so he couldn't find a way. He couldn't find out where to go. So he was just unsure of what was open anymore, what was appointment only, what was he could walk in. So he called for the information off of us. So I gave him all the information and reassured him that, just tried to reassure him the best I could. And then he thanked me and hung up, but he called back 20 minutes later and he started opening up a bit more to me. He spoke about a sex party he was going to be attending very soon, and I think it was 2 weeks after that call. And he was very anxious because he's worried if he did have something, he didn't want to pass it around, or even if he didn't have anything, he was worried about catching something himself. He said because of COVID, he was just extraordinarily anxious of anything related to his health or infections. So he just wanted to be 100% sure that he and everyone around him was safe. But the problem was, the reason he called us, he told me, was he feels like this kind of stuff is very taboo, that he didn't know anyone he could talk to about it, that he didn't want people to judge him. So he called Switchboard because he felt that we wouldn't judge him, that we would, understand and try and give him the right information. So I just confirmed he'd all the information he needed and told him if he is going to end up going to that sex party, regardless if he has an infection or not, just to use protection, be as safe as he possibly could. And our second caller, this caller called twice back in June. So we called my colleague first and told my colleague the story. They had engaged in unprotected sex and wanted PEP as he was concerned about HIV. He was actually seemed to be quite knowledgeable about HIV and PEP, but the issue was he tried to find a local clinic and he couldn't. So he called an out-of-hours doctor and he got referred to a local hospital. But he said the doctor seemed to know nothing about PEP. He seemed to just be completely unaware of it. So he got referred to another hospital. He arrived in the West, and he arrived in hospital's A&E around lunchtime. He checked in, signed the paperwork, did everything he was supposed to, but he was getting really worried because the 72-hour PEP deadline was coming up at 10 p.m. that evening, and he repeatedly pointed this out to the staff at the A&E, but ended up not getting seen, and he ended up just going home after 10 p.m. because the deadline was over and nobody had seen him. He didn't think he was going to get seen. He told my colleague he felt very distressed and failed by the health system, and he knows he's lost his chance of PEP. And my colleague advised him contacting his GP, but his worry was his GP is a family GP and he didn't want his family to find out. So when he called me the following Wednesday, he told me the story that he told my colleague. And his concern now was that he missed out on PEP, but he wanted to be tested just so he could be sure. So I gave him all the information on where he could get tested, what the process is, how to get tested, and he also asked for contact information for any HIV organizations. So I gave him a couple, HIV Ireland and Empower, and I think a couple of others. I don't know if he ended up contacting them, but I think he just wanted more reassurance. He knows he missed his chance for PEP, and he just said he called us for as much reassurance as possible, and he wanted to talk to someone where he wouldn't be judged. And our conclusions on this, based on we've been looking through the call logs, talking about our past calls, that a lot of as Eamonn said, married men and men who are in heterosexual relationships are very high risk. They often seem to not think about sexual health, which they can end up bringing that back home. A lot of older men who call us seem to have very little or no knowledge about sexual health, or they just feel it's irrelevant to them. When a lot of young adults are at risk, a lot of them don't have the knowledge. They may have learned about sexual health in school, but not specifically sexual health for gay men. We've also found on our line, we get calls from a lot of non-nationals. So they might have difficulty accessing services. For example, we've had a lot of calls from members of the Brazilian community, and maybe due to a language barrier or something, they often have difficulty navigating sexual health service websites, arranging appointments, or are just confused by the entire process in general. And Eamonn?
Thank you, Chris. Sorry, I was trying to unmute. The host was unmuting me at the same time. Just to finish up, so just a few things that the Switchboard are doing to try and help in this area, but also in other areas. We just recently trained some more new volunteers. So, they've had excellent training on sexual health from Jason, actually. We'll be involved in PINK training in December. We're sending several people there to talk about various issues, sexual health being one of them. We have a line for domestic abuse and domestic violence, which has been increasing in the community.
Hi, Eamonn, sorry to interrupt. Just your 2-minute warning.
Sure. We have a helpline for chemsex. We've also reached out into kink and fetish community to try to show that we're there to offer support. We're launching a poster campaign very soon. You see 2 examples here, which have been designed by our social media manager, Oliver. We'll have our first employee ever actually soon, Gillian, who is on work placement from the Northwest Partnership. So Gillian will be doing 19 hours per week for the Switchboard. So we're really looking forward to this, and we're always seeking funding as well. Just to say thank you very much to GHM, who recently gave us some funding, and to Dublin Pride also, who gave us funding earlier in the year. Finally, just our 50th anniversary will be coming up in 2024. As Jason said, we are the longest running, continuously running LGBT organisation in Ireland. We're forming a 50th anniversary committee to look forward to this event and to start planning for that. And it can involve people who are not actually in the Switchboard, who have an interest in the history, or who may have been involved at a previous time. So we're having the initial meeting this coming Sunday at 3 p.m. in Hpv Ireland. If anybody is interested in attending that, you're more than welcome. Just let me know by sending an email to contact@theswitchboard.ie. I think we'll also have Zoom capability for that as well. So if you email me, I can send you the Zoom link if you want to attend that event. So thank you very much to Gay Health Forum for having us.
Thanks so much, Eamonn and Chris. And a 30% increase in sexual health related calls to Switchboard, I'm guessing, would also be down to Switchboard now broadening its description so the public are aware what they can contact Switchboard for. And now any sexual health concerns. And I guess it goes without saying, particular mention and acknowledgement to the amazing group of people who are volunteering the time to commit to Switchboard's continued success. So we're going to head over now to Bill Foley, who I have the pleasure of working with constantly. Without any break, I do hand him with a lot of questions. So Bill has been an activist for most of his adult life. He's a founding member of the Dublin Lesbian and Gay Men's Collectives, Gay Health Action Dublin AIDS Alliance, and he is currently a volunteer with Empower and board member of Gay Health Network. And Bill will be discussing mental and sexual health, so I'll hand you over to Bill.
Hi, everyone again. I'm just back to talk about the positive mental health promotion that Gay Health Network was involved in from June Pride of this year. Paddy has already mentioned some of it in his presentation earlier, but I just want to give some background to how we got involved with this issue. I suppose just go back to basics. What is mental health? And the World Health Organization defines mental health as the foundation for the well-being and effective functioning of individuals. It is more than the absence of a mental disorder. It is the ability to think, learn, and understand one's emotions and the reactions of others. Mental health is a state of balance, both within and with the environment. Physical, psychological, social, cultural, spiritual, and other interrelated factors participate in producing this balance. And there are inseparable links between mental health and physical health. The same organization's definition of sexual health runs as follows: that sexual health is an integral part of overall health, well-being, and quality of life. It is a state of physical, emotional, mental, and social well-being in relation to sexuality, and not merely the absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable and safe sexual experiences, free of coercion, discrimination, and violence. For sexual health to be attained and maintained, the sexual rights of all people must be respected and protected. So we can see from those two definitions that both sexual health and mental health are extraordinarily interrelated, and arguably you can't have one without the other. If we look at LGBT vulnerability in this regard, minority stress helps us to understand that a little bit better. I suppose minority stress as a model was first researched in LGBT populations in 2003, and it refers to the additional stress that members of marginalized groups experience because of the prejudice and discrimination they face. The experience of minority stress is additive to general stress and can lead to poorer health outcomes compared to individuals that do not experience minority stress. And the key factors that distinguish minority stress from general stress are that it's unique, it's chronic, and it's socially based. We do get some indication of that from the EMIS findings in Ireland in 2017, and it had some mental health questions. Now, of the men surveyed in that poll, we find that 11% were vulnerable for anxiety, with 8% vulnerable to depression. And those percentages increased for the younger age cohort to 16% for the 17 to 18-year-old ages. The question was put on the survey as well about had they considered hurting themselves or being better off dead in the week leading up to the survey. And of the general population surveyed, 23% answered yes, whereas again, it was higher for the younger population at 30%. When we asked them about being verbally insulted, again, 28% of the general population said they had that experience, while that rose to a whopping 44% of the younger generation. So we can see that despite major advantages in LGBT rights in Ireland over the years, there is still a long way to go in countering discrimination that we experience on a day-to-day level. I suppose in saying that, it is important to recognize that no anxiety or depression was identified in 75 to 70% of the populations, respectively. This somewhat complicated model is basically kind of suggesting the factors that lead us to sexual health outcomes and indeed mental health outcomes for ourselves. So on the left-hand side, you see social representations and social stressors. And these are basically the images that we all grow up with in terms of LGBT identities and images. And a lot of them can be very negative and stigmatizing. And this can be added to in terms of our individual experiences as we're growing up, in terms of the experiences we have and whether we're lacking in self-confidence or have particular experience of abuse and internalized homophobia. And that leads us to experience identity threat and not feeling confident in who we are and the choices we make. And in turn, that can lead us to feel guilt and shame and anxiety about our own identities. And this will lead to maladaptive coping in various things, including in risk-taking and in chemsex parties and putting ourselves at risks there. Now, the good news about this model is that we can enhance our mental health and sexual health outcomes positively by the social supports we have, either from family, from peer supports, from significant others, and also from the personality traits that we have ourselves. So whether we're an optimistic sort of person, self-directed, and so on. And there are also then positive approaches from practitioners. So that's all of us in our agencies or professional counselors and services can positively affect how we feel about ourselves. And I think that's really important in terms of how we are now and creating LGBT spaces that are safe for people of different races, of different ethnic backgrounds, of different shapes, of different sizes, of different sexes, of different sexuality, and of different gender choices. So what did Gay Health Network do about this? Well, as Paudie had illustrated earlier on, we have developed new pages for mental health on the mantoman.ie website, and it goes into an explanation of what to watch out for in terms of vulnerabilities to mental health, as well as keys to maintaining good mental health for ourselves, and a comprehensive list of the support services. So this was the imagery as seen by Paudie earlier on that we loaded up onto social media to notify people of the pages on the website. And as with all man-to-man information, it is in 4 languages: English, Spanish, Portuguese, and French. And it was widely advertised on social media as well as in gay community news. Also, as Paudie had mentioned, we did complement the campaign with 2 short film productions on sexual health and mental health. And thanks to our partners in the network, Sexual Health Centre and GOSH and Empower for help in producing this campaign. So in conclusion, we can see that mental health and sexual health and well-being are all very closely interrelated. And so the onus is on us in all of our service to incorporate mental health perspectives in the sexual health messaging and campaigns that we're putting out. And I suppose if we look at what we're trying to achieve in terms of our messaging, we'll see that it's really aimed at behavior change. So that's a 4-step process. And it begins with information and education about the issue. And then from that, an individual might develop insight and acknowledgement of the fact that there is a problem. From there, we can move on to motivation to action. And once that's achieved, we end up needing to encourage the person to maintain their behavior. So probably no one organization can achieve all of those aspects. And we therefore need to work in collaboration and cooperation with each other around these kind of very complex messages in order to achieve the desired result that we're looking for. Certainly in our Gay Health Network's strategy into the future, we have got a renewed emphasis for ourselves on the importance of networking and campaigning on these complex issues. So we look forward to future network engagement in times to come. Thank you very much.
Thanks, Bill. And a need to work in collaboration and cooperation is a perfect ending point on your presentation. We'll go back over to Phil Corcoran at the Sexual Health Centre in Cork. Again, he's going to be presenting on LGBT plus public sex environment and access to services. So hopefully your tech issues are all fine.
Fingers crossed. Nothing like tech issues to get you relaxed. Okay, so I'm completely unaware of how much you heard. So Alice is actually in control of the presentation for me. So Alice, if you could skip to the next slide, please. So I was just giving an overview of our services and explaining during COVID that many of these services had to move online or over the phone, that we did our condom distribution as a postal service. And between March and July, while we were closed, we couldn't provide rapid HIV testing within that time, but we did resume that shortly after our return. Okay, we can go to the next slide, Alice. Okay, so just in regards to my role, I oversee our rapid HIV testing program, including the training of staff and volunteers. I provide support to people living with HIV. I think when I was cut off, I was just about to launch into my shameless plug moment, which was the fact that we launched the WISE Facilitation program, which was a capacity building piece for professionals engaged in the delivery of inclusive sexual health workshops to young people. And for anyone who's interested in that, that's available from sexualhealthcentre.com/training. I'm also responsible for the delivery of sexual health workshops to people with intellectual disabilities. And we can move to the next slide there, Alice. And shameless plug number 2, I was the co-lead in the development of the In the Know online program in partnership with Belong To and the SHCPP, and that is also available from sexualhealthcentre.com/training. Again, that's a capacity building piece for people working specifically with young GB MSM. So I'm also the Vice Chair of Cork's Fast Track Cities Group, a member of the LGBT plus steering group of Cork City Council, a member of the MSM Health Committee, and I attend the annual European MSM Working Group meetings. So we can skip to the next slide again. Okay, so on my newest role here at the Sexual Health Centre, for all of you who work at NGOs, you know we all tend to wear lots of hats. So I suppose the reason behind the development of this role was that, you know, public sex environments in Ireland are alive and active. And one of our missions here at the Sexual Health Centre is to reduce barriers to access to sexual health advice services and supports. And we need to meet with people who may otherwise be hard to reach in environments where they are actually active. So we will be providing online supports, but we are mindful that not everybody is that tech savvy and that not everybody will be using the geolocation apps or be that comfortable with technology. Okay, so during the outreach sessions, we will be set up in close proximity to public sex environments. We're very mindful that we do not want our presence to cause any of the people using the areas any stress or anxiety. We want to be there in a support capacity. We have reached out to a community guard in relation to the initiative just to ensure that there would be no barriers to the work or increased attention brought to the areas that we would be working in. While at these outreach sessions, we will be providing information leaflets, condoms, signposting to services and supports, and we will also be able to provide rapid HIV testing within those settings, and I will shortly explain how we will go about doing that. So I suppose in planning for this, a mapping exercise was carried out, and with some of these public sex environments, some of them will be seasonal and usage times may differ. Areas that might be attractive in the middle of June will not be as attractive in the middle of November. And as I said, the particular sites' usage times differ, so there was a bit of work into looking at when these sites were actually used. In terms of the outreach work, it will never be done solo, and we will also use a check-in app. And this check-in app will show a person's last location and also require the person to check in at particular times. Okay, so I will be working with Danny, our DASH coordinator, and DASH is also a new initiative here at the Sexual Health Centre, and DASH stands for Drugs, Alcohol and Sexual Health. And as we all know, drugs and alcohol and sexual health, they can often be dealt with as separate issues, but we know that drugs and alcohol use can lead to negative sexual health outcomes, so it makes sense, to be looking at them together. And this DASH van is a joint initiative with Cork Local and Southern Regional Drug and Alcohol Task Force. And the aim of this project is to ensure equity of access. It brings opportunities for informal interventions for many people. So in designing the DASH van, care was taken to ensure that it would not look like a police initiative. We also wanted it to look like a welcoming space. So you can see here on the left, there is a picture of the waiting area within the van. On the side wall, there will be some containers with information leaflets across a range of subjects. And here at the side of the van, you can see that it's inviting people to ask questions. Okay, so here is a picture of another room within the van, and this is the room that will allow us to offer rapid HIV testing when we're providing outreach in public sex environments. This room also has a door which allows for extra privacy for the person who is accessing rapid testing. Okay, so as part of this role, I'll also maintain a passive presence on Grindr, Scruff, Recon, Romeo, Growler, and Squirt. And I'll just give you a brief overview now of some of the queries that we've been getting there. So 30% of those would have been relating to PrEP. We then have had, this is very small on my screen, and I actually can't read the percentages there, but the next highest would have been around information on the services that we can offer. 11% would have been queries for rapid HIV testing, 10% for STI screening. We would have had 5% of people then with very specific questions around sex. So maybe safety around certain sexual acts, for example. Okay, and I think that's me. Oh yeah, sorry, I'm just moving on to last summer during Pride, we ran a billboard campaign. So it was #PhonePhil. I suppose we're trying to get people more familiar with the people that work here and to put a face to the services, the people behind the services that we deliver. And I was the first out of the box on that one. So here is the weekend version of me, who looks slightly different to the weekday version, with one of those billboards which we ran during Cork Pride to publicise the support services that I offer here at the centre. Okay, second time around was better than the first. So thank you all for listening and for your patience.
Thanks, Phil. Tech issues were definitely worth it, and there's no shame in self-promotion, obviously. So next up, we have Dr. Chris Noon, who's a lecturer in the School of Psychology at NUI Galway and a board member of the National LGBT Federation. Dr. Noon will be speaking today on the topic of chemsex harm reduction.
Hi, everyone. Can you see my screen?
Yep, it's all shown.
Okay, great. So thanks very much for the invitation to speak today about a project that I worked on with Adam Shanley from Empower, and that focused on exploring the harm reduction strategies that are used by men who engage in chemsex in Ireland. And this speech bubble here, it's good, it's bad. You know, that's a quote pulled directly from our data. And that just shows that chemsex is not something that we can take a simplistic view of. It's a multifaceted phenomenon, and the specific lens that we wanted to take in speaking to men was one of harm reduction. And I'm going to present some of the information that we found. The work was funded by Hpv Ireland with some support from NUI Galway College of Arts as well. And just want to thank Hannah Fitzsimons for research assistance and Ben Meehan for advice and analysis. And the aim of our research was to explore how harm reduction is understood and achieved by men who engage in chemsex in Ireland. So it was an interview study that took place during a quite challenging time between May and June 2020. So it was during our first lockdown. So as a result of this, our sample was not very large, but we had in-depth interviews with 8 participants who live in Ireland and had engaged in chemsex. All of the participants were gay or bi men. They were all aged over 18 and had engaged in chemsex at least once in the previous 12 months. We recruited some participants through social media, and a couple of these participants recruited onwards for us by recommending the study to friends of theirs. And we had ethical approval from the School of Psychology Research Ethics Committee at NUI Galway. So who did we speak to? Well, they were all gay men except for one who identified as mostly homosexual with some heterosexual feelings. The mean age of these men was 36. The youngest was 31 and the oldest was 44 years old. 4 of the participants were born in Ireland, 2 were born in Africa, and 2 were born in South America. All of the participants reported having 3rd level education and were single at the time that we spoke to them. And 2 of them were currently living with HIV, and the other 6 participants had reported previous or current use of PrEP. So we conducted semi-structured interviews. This meant that we had a specific guide of the kinds of questions that we wanted to pose, but that there was flexibility to go where the participant wanted to go as well. And these interviews were recorded and then professionally transcribed. And afterwards, they were anonymized and the original recordings were deleted to preserve confidentiality. Before each interview, we engaged in a screening protocol to ensure that participants were in a good place and that they felt comfortable with proceeding with the interview. And all of the interviews lasted between 44 minutes and so between three quarters of an hour and 1 hour, 1 hour and a quarter. So the interview guide, the kind of questions that we focus on, started with motivations for engaging in chemsex. What are the positive experiences that people have had during chemsex? What were the potential harms that have been experienced or observed? The kinds of strategies that they use or have seen others use to try and avoid harm or reduce harm. And we also talked about usage of health and community services. We used an approach called thematic analysis to look for patterns in the data, and 5 themes were identified by myself and the research assistant. And the first theme we named harm as a norm within chemsex. And this reflected a pattern of the participants talking about different types of harms being inevitable as a result of engaging in chemsex. So things like dealing with the after effects of chemsex the day after, both on a physical level and in terms of how that could have an acute effect on your mental health. Was that fed into this theme. Discussions around consent and how consent is perceived and understood within the context of chemsex, and how this can lead to problematic outcomes, also fed into this theme. And then the idea of stigma of sex between men and stigma of drug use, and how these different types of stigma intersect, being a barrier to engaging in harm reduction, and in particular a barrier to attending services. So a quote related to this is the following. I remember I was talking to a lad before. I was telling him about the needle exchange program, and he was like, "No way, everyone would think I'm a drug addict." And this kind of this kind of discourse between being someone who uses drugs and being a drug user or a drug addict came up quite a bit in the data. The second theme we named self-managed harm reduction, and the kinds of things that fed into this were the practices that the men engaged in during a chemsex event to try and reduce harm. So being able to assess the environment for things that were potential risks or things that they were potentially uncomfortable with, checking these against their own boundaries and trying to establish and maintain boundaries around what they were willing to engage in and not willing to engage in, on both the level of sexual practice and drug use. The issue of control and how to some extent you want to maintain control during a chemsex event, but also how that's complicated by part of the point of engaging in chemsex for some people is to let go. And then maintaining awareness of your own limits, and the importance of that for reducing potential harms. So these issues are addressed to some extent in this quote, where we say, one participant said, "I like being in control as well. I think Tina or crystal meth or whatever, ice, one of them ones that could maybe be a slippery slope. I don't know. Not saying I wouldn't try it, but I would definitely opt to do it in a control space with a lot of time either side to come down if it was that intense or something, you know." So thinking about it, thinking about his boundaries, and trying to balance that against his wish to be in control, assessing the risks of taking a different approach to what drugs he might use, and balancing that against his own limits, his own awareness of his own limits. The next theme then focused on things that happen before engaging in chemsex or between chemsex events, and we named this planning as a harm reduction strategy. So this involved people informing themselves, planning when to participate, when would be a good time, planning the kinds of drugs they will use, and planning the kind of environment they want to be in. So a quote along these lines is, "I can't have drugs in the house, I suppose, because there's a chance, particularly with crystal, there's a chance that I could have it on a Monday or Tuesday just to get through the day. A very slippery slope. It suits me better to go to somebody's place and they have drugs, and I give them money for it rather than for me to buy the drugs, because if drugs are left here, I don't like it. I wouldn't trust myself with it." So there's an element of planning there.
Hi, Chris. Sorry to interrupt. Just your 2 minutes.
Yeah, thanks. Moving on to a theme that we called interpersonal harm reduction. This focused on how men look after each other within chemsex environments, and the importance of a kind of an atmosphere of support within these environments, an atmosphere where there's open communication about how people are, and an atmosphere where there's respect of limits and boundaries and the extent to which people are in control. So along these lines, we've got a quote saying, "I've seen it, and I've stopped people who in my mind aren't in the right mind to give consent, and other people that just aren't stopping when they realize that this person is close to passing out or going to go unconscious or go under on G." So this idea of kind of being an active bystander and stepping in came up a lot. And finally, there was a theme focused on awareness, availability, and accessibility of information and services. So this was focused on being able to access advice related to chemsex, being able to access services that are non-judgmental, and being able to trust the services that are out there. This comes up in the quote here: "Something that people trust is needed. They're not afraid of getting touched a service, but it's not somewhere you're going to call. You're going to feel and you'll feel harassed, or I don't know, or judged." So in general, the participants spoke a lot about how they care for themselves and for others, with the aim of minimizing the potential negative consequences of chemsex. We saw that there are different skills involved in reducing harm. These can be things that you work on before or between sessions, or during a chemsex event. And there's a need to develop interventions that can support these different practices and provide support at the appropriate time. And an area of concern that was identified again in this study is that there's stigma attached to chemsex that can prevent men from accessing the support that they need when harms are experienced. So yeah, thinking about interventions on the institutional level, the community level, the social level, and the individual level is something that would be useful. And there are some suggestions for different different factors related to chemsex on these different levels here. And just quickly, some limitations of the study. It was obviously quite a small sample, convenient sample, and there's a lot of voices missing here, particularly younger and older men, and maybe men who don't have the same level of education as those in the sample. It was obviously a very particular circumstance in which we collected the data because of the lockdown. But a really great outcome of this research was the development of the Sex Party First Aid Guide by Empower. And this is part of a suite of interventions that are planned there by Adam and the rest of the Empower team to support those who engage in chemsex. So thanks very much for listening, and happy to answer any questions that you have.
Thanks so much, Phil, especially on the presentation and topic that really does require more signposting and accessible information. Ending out this session 2, we have Conrad in from Sexual Health Centre in Cork. After this, we'll go to a quick Q&A, and it'll be followed by a 5-minute break. And then on to session 3. Conrad joined the Sexual Health Centre in August of 2020, and his role is to provide sexual health advice and support on a wide range of matters. Having recently graduated from CIT's Bachelor of Arts in Community Development, Conrad's undertaken currently a Master's in Voluntary Community Sector Management in UCC. Through his many volunteer roles, not limited to Hpv testing campaigns, Conrad will be discussing sexual health support, responding to the community in an effective manner. So I'll pass it over to Conrad.
All right, yeah, thanks, Emil. I'll just open the slides. There we go. So yeah, thanks a million for having me on today. As you just pointed out, I'm going to be looking at LGBT sexual health support and how we respond to the community in an effective manner through my role in the Sexual Health Centre. As you know, healthy, respectful relationships are crucial for positive outcomes to individual well-being. However, societal norms dictate that sexual health discourse and dialogue tends to be very heteronormative. Research highlights the lack of focus in supporting romantic relationships of LGBT people, despite evidence of relationship-oriented risks, including STI and HIV infection, unflagged pregnancy, and interpersonal violence. And as we know as well, isolation, anxiety, disconnect, and uncertainty remain interconnected with growing up in Ireland as an LGBT person. And so LGBT individuals lack education, insight, and supports for good, healthy relationships, sexual health practices, and protections. So then in responding to this, the Sexual Health Centre appointed a support worker in 2019 to provide LGBT people with one-to-one and small group support focused on specific issues. So I took up that role myself in August 2020. Just a bit of background on myself, as we pointed out in the bio, that I am involved in many of the different LGBT organisations around Cork, on the board of different organisations, and been previous chairperson of the LGBT Society in CIT, now MTU Cork, and as well as a youth group leader with the LGBT youth group in Cork. I have studied in basically almost all of the colleges in Cork, so this experience has been beneficial in my role, having built a network previously that we can utilise now. My role itself is to provide sexual health advice for LGBT people, focusing on healthy relationships, sexual issues, sexual function and dysfunction, interpersonal violence, and sexual orientation. I also provide sexual risk information and brief interventions focused on reducing risk. We do one-to-one support for anyone that might be struggling with coming out in relation to sexuality and gender. And that one-to-one also extends to family members that might be struggling with their young person that might have come out, and they want to know more about how to best support them, but also supporting and navigating relationships with family and peers. And then as well, we provide sexual health advice and training for youth workers, professionals, working with LGBT groups and the general population or individuals. So I'll go a bit more into detail on this now. So with the one-to-ones, we provide them free, and they again focus around sexual health, as a sexual identity, gender, coming out, and healthy relationships. I started during the pandemic, so I'm only recently started doing in-person one-to-one sessions, I think in March, but we provide it in person, on Zoom, through email, over the phone, on WhatsApp, and on Grindr. This is building the aim of the one-to-ones. It's not counselling, it's more trying to build internal capacity by using motivational interviewing styles and by using the 5 steps for change. And we provide it in all these different forms to reduce barriers and to meet people where they're at. When it comes to community capacity building, we do a range of different workshops throughout the year. So for HIV stigma busting, I suppose, we did workshops for World AIDS Day. We also worked with the Up Cork Youth Group for the young people to create their own workshop using their own voice, kind of using what they want to learn and what they need to know. And then they facilitated the workshop for their peers in LGBT youth groups around Ireland. And then as well, we do kind of online stuff during COVID. So as we know, going home for holidays can be more of a struggle for some LGBT people. They might be going back to hostile environments, or they mightn't be out to their family. So we try to provide information during Christmas around navigating relationships if you're in that situation. We also then as well do the professional training. So we give free workshops for capacity building around LGBT awareness raising and around HIV and different topics that are LGBT related. So this year we've done them with Dell, with PepsiCo, TELUS International, and we did the coming out talk for Explio this year. And also we do trainings for the various educational institutions, including the universities and secondary schools, but for training for staff of secondary schools. Then we also do our online sexual health promotion. So we are delighted to be able to collaborate with people like Mia Gold, who have a following that we mightn't have ourselves. Mia has worked with us on the World AIDS Day campaigns, and we recently did a video as well showing Mia going in and how to get the free rapid HIV test with us. This week, I was delighted to finally be able to go back out in person to meet people. So I was in the College of Commerce here in Cork for National Coming Out Day on Monday, and we were just giving out advice and free condom packs to students. We are very lucky then as well to be able to collaborate with different organisations. So as Padraig mentioned earlier, we were able to collaborate man to man on the videos around mental health and around sexual health. So that was brilliant. We also then, as Phil pointed out, did a billboard campaign during Pride. So we had Phil's billboard, but we also had Taking Pride in Your Sexual Health campaign. And Pride partially funded the billboard.
Hi, Conrad. Sorry to interrupt. Just your 2 minutes.
As well, we created a Pride guide with Pride. So this is once off funding, and it's a guide that has over 200 different terminology, LGBT terminologies and their definitions. And this has been handy because we get asked a lot about doing workshops around terminology. People always find it the most difficult part of working with LGBT people. So we've been able to give out the guide now to the different services in colleges and in healthcare and different areas. And at the moment, we're working on a resource for lesbian, bisexual and queer women in collaboration with LINK and the HSE SHCPP. So that will be released in November. And it's just looking at, there's a lack of information that's there for LGBTQ women, and we're working with the community to create the resource around sexual health and healthy relationships. And so then we're hoping to expand that with our work with the Gay Project later in the year as well, to provide another resource for men that isn't solely focused on STIs and HIV, but gives more advice about healthy relationships and dating and things that we would have wanted to know as young men growing up. Then finally, we're also working with the LGBT Society and MTU Cork to create videos around coming out terminology and consent and different topics. And these will be released later in the year as well. So they're animated videos. And last slide. So the response since I started in August 2020, so it's a 2-day-a-week position, but we've had 576 participants in capacity building workshops. I've done 110 one-to-ones with clients. Some of these are repeat, others come once, and we find them the services that they need access to. Then I've had 99 net reach on Grindr, so we have our own work account to provide support and information to people, and what's been coming up the most has been questions around rapid testing, a lot of questions around where to access PrEP, people looking for condoms, and also for STI screening information. So this results then in referrals to our own services or to other relevant services. So hopefully I'm on time. Thanks a million.
Thanks so much, Conrad. Great to hear you're out and about meeting people. Apologies to Chris. I called him Phil at the end of his presentation, so I do apologize for that. So now we'll open up to the Q&A. There was a comment that was sent in by John Gilmore that I'd like to present. So John has said earlier this year there were social media posts advising people not to go to emergency departments if they need PEP. How can we ensure this doesn't happen again? So if anybody feels able to pick up this comment and respond, that'd be great.
Yeah. Hi. Yes. Thanks for your comment, John. Yeah, I remember the post, and some of the copy in it was about accident and emergency beeping, usually for like accident and emergencies. It was lifted straight from the restrictions page, and I guess it was a bit ambiguous. It wasn't telling people not to go to the page, because the tweet was here, or sorry, the post was here's information on PEP and here's where you need to get it. But yes, I can understand how that sentence about A&E usually being for, serious injury. So immediately I went to try and change the copy, but I couldn't because it was a boosted post, so I deleted it. And I can assure you that every PEP post since has stated implicitly to go to A&E if you within 72 hours if you can't get access to sexual health. Right. So yeah, thanks.
Okay, that's perfect. I think that's all we have time for on this Q&A. So we'll wrap this one up now, take a quick 5-minute break, and then we'll be back for our session 3. So go grab a coffee, tea, or wine if you like.
Hi, everybody. Good afternoon, or almost good afternoon. Welcome back. Apologies for that slight delay. Hi, everybody. Good afternoon, or almost good afternoon. My name is, apologies again for that. My name is David Carroll, and I am a PhD student in sexuality studies at Dublin City University and a board member of Outhouse LGBT Community Centre. And I am really delighted to have been asked by the Gay Health Network to introduce and chair this session, the 13th annual Noel Walsh Memorial Lecture. The title of the session is The Migration Experience, and we have three, what I can assure you, are really interesting and diverse presentations from Daniel, Bulalani and Fernandos also. But before we kick off, I suppose I want to say a word or two about Noel Walsh, who the lecture, of course, is named after. So for many of you today, zooming in from across the country and beyond, you will be aware of Noel's legacy. You probably, working in the sexual health field, may have met him and indeed had the pleasure of working with him. But for other people who maybe got involved in sexual health in the last couple of years, you mightn't have had the opportunity to meet him. Believe you me, I think there's a clear distinction. No one is ever in doubt as to whether they did meet Noel Walsh or not, because his presence and his personality were just so big. He always made an impression. To Noel, work was the most important thing, I think, and his work was varied and really well accomplished. His work with the Gay Health Network, of course, in many guises. His pivotal and I think really pioneering role as the health editor for the health and HIV editor for Gay Community News, a role which he held for many years. His really important contribution and representation on the National AIDS Strategy Committee, and indeed his work on earlier iterations of the very forum that we're enjoying today. So again, these are all kind of, I think, testament to Noel's accomplishments. But in thinking of the theme of today's Noel Walsh Memorial Lecture, the migrant experience, I began to really realise that I think it fits with our experience of Noel. We got Noel Walsh at a really perfect time upon his return from his own migrant experience in the United States. As an openly positive man, he challenged us all, he challenged Ireland to respond with a response as robust as the one he had witnessed in San Francisco, in his beloved San Francisco. So we learned an awful lot from Noel, and I think as such, we will learn an awful lot from these presentations today. So before I go ahead and introduce Daniel and the first presentation, I would just like to do a little bit of housekeeping reminders. So again, you'll get a 2-minute reminder in the chat. And I'd also remind all of the presenters to stay logged in for questions at the end. In terms of questions you might have, please do log them in, and you might say your name and an organization of relevance if it's applicable. So moving on to the first speaker today, I'm absolutely delighted to introduce you to Daniel McCartney. Daniel is a doctorate PhD scholar at the London School of Hygiene and Tropical Medicine. Daniel has been a volunteer researcher with the Gay Health Network for many years, and of course is familiar to many of you. For the past 10 years, he's been based in London, working for the International Planned Parenthood Federation, which is a global service provider and advocate for sexual health and reproductive rights. And previously he was based in Trinity College, Dublin. Daniel is going to present on MS migration data from 2020. So you're very welcome, Daniel, and over to you.
Great, thanks. No, it's great to be here, and in particular, to be a part of this Noel Walsh session as well. So it's really great to have this opportunity. But I think what I wanted to do is really take this opportunity to sort of set the scene for the other presenters and the exciting talks that will follow this session, as we're talking generally about migration and needs of migrant MSM in Ireland. So some of the information I'm going to share won't be new. That is coming from the EMIS European Men Who Sex with Men Internet Survey. So I know you've heard about this if you've attended any of the gay health forums in the past few years, but we're going to specifically zoom into a little bit more information around migrant MSM. Overall, the main report was from over 50 countries, including Ireland, and you can see that was over 120,000 respondents from across these countries. And from those who responded from Ireland was just over 2,000. So you can both see the full European report as well as the specific Irish report, which was launched at the end of 2019. You can see that the links there. So that report specifically gives some information around the respondents from Ireland. So what we had done as well, and what we presented at the last Gay Health Forum, were some of the Irish community reports that we had done. And one of them particularly was to share the findings of the 514 men who indicated they were not born in the Republic of Ireland. And again, I'm not going to go into this report in depth today, but you can download it specifically from the Gay Health Network website. But in that report, what we did do is share some of the information about why these migrant MSM came to Ireland. So any of those who reported that they weren't born here, they were also asked to ask some specific questions about why they came to Ireland. Many of them said, to work, to study, but we were also able to get some interesting information, in particular of those who said that they came here to live more openly as gay or bisexual. So that's what we saw. I mean, a number of 77 respondents saying that that was the case. But we were also able to see who indicated that they had come here as a refugee or asylum seeker. So, we didn't get that many, but we had about 4 respondents that came from 3 different countries. So overall, we were able to look at these different categories. Unfortunately, with the Irish data specifically, we weren't able to do any further investigation because the numbers were just too small between these different categories. So in this community report, we were able to just overall, share just the understanding of those who were born in Ireland and those who weren't. And that's what the community report was able to do. But this was possible in the main EMIS report of the over 120,000 respondents, because while we see that the proportions were similar between these categories, we just saw much greater numbers. So it really did enable the main investigators to dedicate a specific section in the main report to investigate any of these key differences between these migrant groups and against those who against all respondents as well. So this is some of the information I wanted to share today. So for this presentation, it was just sharing the information from the main report, but in particular, this section on migrancy inequalities, which you can find in the main report. So what I will include is some data reported by these 3 migrancy categories. You'll see this box on the next sections as well. So around those who said they were refugee or asylum seekers, those who came to live as more openly as gay or bisexual, and then all other migrants against all those who were respondents of the survey. So overall, this should just give us a bit of insights on the possible needs of migrant MSM, in particular for refugee and asylum seekers in Ireland, since we weren't able to look at this specifically in the report for Ireland previously. So overall, I'll just give some general data will be on the screen, but I'll just give a few insights from the report. So we did see that refugee and asylum seekers were much less likely to be out to their friends, families, and other work colleagues. They were also more likely to report being a member of an ethnic or racial minority. But unfortunately, refugee and asylum seekers were also experienced a higher level of homophobic abuse compared to other migrants and the wider survey respondents as a whole. With regards to mental health, we did see that, again, that refugee and asylum seekers were more likely to have poor mental health and also substance dependency, including more likely than average to be injecting drugs. But overall, non-migrant MSM as well were just significantly less likely to report any mental health concerns. So overall, we were seeing more reporting of mental health concerns amongst any of the migrant MSM, but again, in particular for refugee and asylum seekers. With regards to sexual health and well-being, there was a number of indicators being the type of survey it is. I'm just giving you a little snapshot, but we did see in that report that refugee and asylum seekers were more likely to be recently diagnosed with HIV and overall to have detectable HIV. So they're more likely to have detectable HIV or detectable viral load. All other STIs, and I've included syphilis as an example, appear to be actually more commonly experienced by men who migrated to live as gay or bisexual men. And then we saw overall that non-migrant MSM were significantly less likely to report any infections in the last 12 months. But overall, the report did note that sexual risk with non-steady partners and combining drugs and sex were most common among men who had migrated to live more openly as gay or bisexual. And when we were looking at refugees and asylum seekers, they were less likely to be using PrEP, and the level of use of ART was noticeably lower for those who were diagnosed with HIV. Lastly, looking at self-reported sexual healthiness just generally provides an interesting indication of overall sexual health and well-being. And here you'll see that the higher percentage who said that they scored less on that scale were amongst refugee and asylum seekers. But importantly for this and for the session was just highlighting some of the needs and support potentially for migrant MSM. So we did see that from the majority of indicators related to various needs, that refugee and asylum seekers were most likely to be in need of access to specific prevention interventions, including hepatitis vaccination, access to HIV testing, access to condoms. But the proportion of refugee and asylum seekers lacking social support was also notably high. So you see that they most had said, high proportions that they were lacking such support. But some of these needs are also highlighted on the next slide, where we had that the report saw that refugees and asylum seekers were less likely than others to encounter information about safer sex. And they were most likely to have various educational and informational based needs, including their awareness of PEP and PrEP and the important message of U equals U, or that a person with undetectable viral load cannot pass on HIV. So these are some of the sort of indications that at least it is showing that overall that there is a specific need there that's missing, a gap that likely also needs to be reflected here. So overall, we were able just to at least see some of the specific needs that different groups of migrant MSM, especially refugee and asylum seekers, may need. And while these findings were from the main report of over 50 countries, I'm sure we can be reasonably confident that many of these needs would be similar here in Ireland. But I think what we do need, though, is a bit more research and dedicated programmings, in particular to help us better meet the diverse needs of men from different backgrounds, in particular on these themes that are listed here. As we know, meeting diverse needs creates interesting opportunities, but also challenges for service provision and programming, and that we just really need to try to, how can we do things different that go beyond our conventional programs for gay, bisexual men and other MSM. So I will leave it there. And definitely, I look forward to hearing from the other panelists who I know will bring some interesting context to this topic. So again, thank you very much for this opportunity to be here today.
Daniel, thank you so much. As always, a really informative presentation, and I think you've done a really amazing job at kind of setting the scene for us in relation to the thematic kind of flow. And we'll move on. Oh, I should ask people again, questions or comments, please, for Daniel, please type them into the box there. But moving ahead now, I'm going to move on to our second presenter. Again, I've had the pleasure of presenting this man before at conference, and know he makes for an absolutely fascinating speaker. So Bulani Mfako, to give an introduction, he grew up in the apartheid ghetto of Cape Town and became involved in an early age in protests for housing and access to land, healthcare, and improved policing in his neighbourhood. In 2017, he came to Ireland, where he claimed asylum, seeking protection from violence and targeted killings of LGBT people. He's one of the spokespeople for MASI, the movement of asylum seekers in Ireland, where he's campaigned on issues such as the right to work and the end to Ireland's notorious direct provision centre. Bulani will be familiar to many of you as a voice of advocacy for asylum seekers and refugees, particularly in the LGBT community in recent years, with contributions in gay community news and in various forums across the spectrum. He's on the board of the Irish Council for Civil Liberties and is also part of a coalition of anti-racist campaigners in the EU. And I believe Bulani is going to present today on access to healthcare for asylum seekers. You're very welcome, Bililani.
Good morning and good morning to everybody. That should be up. I'm going to ask the person navigating on the slides to move on very quickly. So when I don't, maybe at the end of each slide, I'll just say you can move on to the next slide because I can't do it myself. I'm currently logging in from a mobile phone and in the library. So my name is briefly Bulelani Mfacto. I'm currently doing research in TU Dublin on the system of direct provision and testing whether or not the conditions in direct provision meet the threshold for inhumane and degrading treatment. Contact details for the movement of asylum seekers in Ireland I've included in the first slide, so you can move on to the next one, please. Trigger warning there for people who have experienced or affected by sexual violence and suicide, because we might mention that in the discussion I'm about to engage in. You can move on to the next one. The movement of asylum seekers was formed by asylum seekers to advocate for the needs of asylum seekers in a direct provision center in Kinsale Road in Cork. And that protest lasted for about 10 days. They locked down staff from the direct provision center as a way of raising the issues again. Very stark reminder for people who aren't familiar with the direct provision center. It was also the site of a heartbreaking scene where a survivor of violence died by suicide in the same direct provision. So mental health issues were at the forefront of that protest. It was one of the many black cards there you can see pointing out that quite a lot of people in the system back then, that would have been 2014, a very different time in Ireland where asylum seekers weren't allowed to work at all. So they were confined to direct provision centers for long periods of time. Some had been there for more than 5 years, for instance, waiting in limbo. You can move on to the next slide. They highlighted the issues and the squalid conditions that they were living on. And of course, these conditions would vary from person to person. Some people, for instance, come on their own as single people, would have different challenges in comparison to people who, for instance, come with their own children. Again, people with disabilities would have their own challenges in a direct provision center, and would be the same for LGBTQ plus people who live in direct provision centers. Direct provision centers. We'll explain the relevance of the conditions in terms of healthcare as we go on. You can move on to the next slide. One of the biggest challenges that contributes to mental health problems in direct provision is the limbo, the uncertainty that people have that they could spend years and years in direct provision, at the end be served with a deportation order. So you could have, for instance, people who spent 10 years. When I moved into a direct provision center in 2017, I asked the person who was fixing the television in the room how long the person who had occupied the bed I'm about to occupy had spent in that direct provision center, and he said they had been there for 10 years. I'm in my 4th year in direct provision now, and before I arrived in Ireland, I had no need for mental health supports, or I wasn't dependent on pills. But when I got into a direct provision center, my doctor prescribed sleeping pills for me because I was suffering from anxiety. And so you get people who have very different experiences of trauma from in their home countries, and different experiences of trauma in the system of direct provision, sometimes in the migration journey as well. And the way the Irish state meets the needs of asylum seekers in terms of mental health is mainstream services that you all have access to via the HSC, and we know that there are long waiting times to meet with a therapist with the HSC. You can move on to the next one. HIV, I think the first speaker has already touched on this, that asylum seekers have limited access to sexual health services in general. And this would be maybe because of the location of direct provision centers, that they are far from the public health facilities. Like I live in Noblashin and don't have access to public transport to the sexual health clinic, which is the nearest to me, is the regional hospital in Limerick. I had to pay a taxi the other day to take me into town in Limerick City, and then from the Limerick City Centre, I had to take a regular commuter bus into the regional hospital. For a person who lives in a direct provision centre, getting 38.80 per week, paying for a taxi fare to get to a hospital may be a big ask because they only get 38.80 per week, especially if they are not allowed to work. You do find people who aren't allowed to work. So you can imagine the situation of an LGBTQ plus person who's just landed in the country and is placed in a direct provision center in a rural area with no access to public transportation. Having access to services like that would be very challenging. I do go to the clinic, but it's still a big ask to ask any person to pay for a taxi when there is no access to other forms of transportation that are cheaper. Again, a presentation by Dr. Boyle. Dr. Boyle works in the Balseskin Reception Center, where most asylum seekers would have gone through, especially before 2018. At some point, the provision centers were full, and that meant that asylum seekers weren't going into Balseskin, where they would be offered a health screening. If you open the link on the on that, you don't have to open it now because it might take a while. But when you open that presentation, you'll notice that there is a stat there that says between 2000 and 2017, there were about 380 people diagnosed with HIV in the Balseskin Reception Center. Testing by 2016, a year before that, was prepared by Dr. Boyle, was around 80%. So about 80% of people who came through the direct provision system had, in 2016, availed of testing when they went to Balseskin Reception Center. So you had a very high proportion of people being tested. But then again, when direct provision centers were full, people were placed in emergency direct provision centers where they had no access to such a service, so there wasn't a screening and there wasn't the support that would ordinarily be available. So for instance, I would have met a person who needed HIV medication, so they were diagnosed in their country but didn't know how to access it in Ireland. They were placed in a hotel. The hotel had no idea how they would go about having access to that, but if they had gone through Balseskin, they would have had the benefit of being referred to one of the service providers in order to access those services. Again, stigma is another issue. People who are taking HIV medication would find it difficult to take that medication in a situation where they share a room with another stranger in a direct provision center because they don't have privacy of having to take the medication, and if other people find out that they're taking HIV medication, that could make life miserable. And people have spoken about this in direct provision. You can move on to the next slide. Again, mental health creeps up because again the situation of people who have been through traumatic experiences, having to wait for a long time before they can get determination of their status. Again, you have to wait a long time to get an appointment with an HSE therapist. You have to wait a long time to get an appointment with Spirasi, who are the only organization in Ireland that is recognized for providing supports services to survivors of torture and inhumane and degrading treatment. And there are asylum seekers from the LGBTQ plus community who have experienced torture for no reason other than their sexual orientation, who will wait for those appointments. And so mental health, access to mental health care in Ireland is in general appalling, more so for people who need it as urgently as asylum seekers. In Mercy, we've always said that asylum seekers should be provided with the service on arrival because of the enormous trauma that people would have gone through from their own country. You can move on to the next slide. I won't dwell on this one, but suicide and attempts, people making attempts to take their own lives are very rife in direct provision. We've had experiences. Just this year, I was called by the guards because they had managed to stop somebody from taking their own life in Dublin city centre. And that just reflects the nature of calls that we get, and we aren't trained ourselves to actually respond to such calls, but we have to, because asylum seekers only have our contact details, and some of them may arrive with nobody, or knowing nobody in the state, and then they will put as a next of kin whoever's mobile number they have in the asylum process, whatever friendly face they've spoken to, they will add that, and somebody added my details there, and I had to respond to that call. But that just reflects the nature of calls that we get from people seeking asylum. You can move on. You can actually skip through the slides on the suicides. I won't dwell on them. You can skip that one through. Again, decisions are very stressful for people in direct provision, and they contribute to the mental health problems, because when a person gets a decision saying that their asylum claim has been rejected, it means that they may be returned to there's a chance that they will be returned to their home country, and then they start thinking about the situation they fled, and that causes an enormous stress. You can move on to the next one then. And then, of course, there is the segregated nature of direct provision centers where people live far from other communities. In some direct provision center, they might actually be within the community. So you have, for instance, in Limerick, 2 direct provision centers that are right in the city center, but they remain invisible to the members of the public. There are people who work next to that direct provision center who don't know that it is a direct provision center. And in some cases, you'll find that people experience isolation even if the direct provision center is within the city center. And for LGBTQ plus people, it's specifically isolating because they would experience bullying within the direct provision center, and so it becomes very important that they have peer-to-peer supports from other members of the LGBTQ plus community. While I was in Balsaskin, we used to meet in Outhouse. When I moved to direct provision center in Noklashin in Clare, there was no outhouse in Clare. If you live in County Clare, you would know that there is very limited activities of any sort for LGBTQ plus people. Or in fact, there was a group that was formed just this year in Clare for that specific purpose. And so peer-to-peer support is very scarce. I've already spoken about the rooms. You can scroll through those photos just to show people the types of rooms that people might be placed in. You can move on to that one. And yeah, just the types of rooms that people would be normally sharing. And 3 people who stayed in that particular room, that is in Newbridge, Airport Direct Provision Center in Newbridge, all tested positive for COVID-19. And so the congregated nature of direct provision meant that it would be difficult for people to protect themselves against COVID. And again, they weren't allowed to claim the pandemic unemployment payment at the start of the pandemic. Only in August last year, the government made the decision to include asylum seekers for the purpose of accessing pandemic unemployment support. So there's a policy of restricting access to income supports for people, but as well as people's right to work so that they can gain, they can earn their own living. Again, you can move on to the next slide there before I conclude. Women asylum seekers have had to resort to selling sexual favors in order to make ends meet. Because if you were back then, that report was in 2014. There is a recent piece that was done in 2019 by the Irish Times. I haven't included that one there. But when you have limited income, it makes life very difficult, especially when you have other responsibilities. So things like condoms, for instance, you have to buy condoms in Ireland. Very few places where you can get condoms for free, and those spaces might not be accessible to asylum seekers. We received condoms, for instance, from the Sexual Health Center. I think they are based in Cork. They sent condoms to a few direct provision centers. We had asylum seekers commenting on WhatsApp that the condoms were taken up very quickly. So there was a clear need there for them to be provided, but people generally wouldn't have access to those. It's the same for when you need to have access to PrEP and testing facilities. If you need to travel from the direct provision center to the place where the testing is available, it becomes difficult. In Balsaskin Reception Center, it's easier because the testing is done in Balsaskin. There is a health center there that does the testing. But once you've moved on from there, it becomes difficult to have access.
Apologies, Granny, just to your final 2 minutes, just to let you know. Thank you.
Cool, thank you. And so the movement of asylum seekers organized, you can move on to the next slide. And just to say that men too do sell sexual favors in the asylum process. Again, survivors of sexual violence receive very limited supports within the direct provision system. They would depend on places such as the Dublin Rape Crisis Center. And there are people who, both men and women and children, who experience sexual violence both in their home countries before living and in Ireland, and they find very limited support within the direct provision system. We've had incidences of sexual violence within the system of direct provision itself. And again, limited support, we get those calls, but we are actually not a service provider. We are an advocacy group, we are a campaign group. You can move on to the next slide, Em. So we continuously organize and campaign for access to work, the rights of asylum seekers. The very basic, simple line I could give you that we campaign for asylum seekers to be treated no differently to the way the other state treats Irish citizens in terms of accessing public goods and services. Where those services are appalling, of course, we advocate for improvement, especially in healthcare. Thank you.
So much for a really, really widespread and informative presentation. Again, I think the image in particular, I think of the Direct Provision Centre in Athlone there is just so stark, and it's a somber reminder, and one that is really, really important for us to not forget. We'll move straight on to our next presenter before going to questions. Again, please do post any questions or comments to Bilalani in the comment section. But I'm now going to introduce you to the third speaker today, who is Fernandos Ongoli. Fernandos is the one person I haven't had the opportunity to meet yet, so hello, Fernandos. And Fernandos is a medical anthropologist whose research interests are in health innovation, behavioural science and implementation science. He's currently pursuing a PhD at UCD under the Misfires project and has wide experience of conducting qualitative research in both rural and urban Kenya, which focused on sexual and reproductive health. He moved to Ireland 2 years ago, before that working in Kenya's Medical Research Institute as a social scientist and a technical advisor for a project implementing HIV pre-exposure prophylaxis in public HIV clinics in Kenya. His current research here at UCD is on the rollout of PrEP in sub-Saharan Africa and Ireland, with interests on mapping out the role of activists and other PrEP actors in influencing the scale-up of PrEP as a HIV prevention intervention. And I think Fernandos is going to talk to us today about navigating through health in Ireland, a migrant story. You're very welcome, Fernandos.
Okay, thank you very much. I'm just working on my presentation to come up. Yeah, so thank you. And I'll try as much as I can not to repeat what Daniel and Mfako have already said. So I'm going to give not only my personal experience as a migrant in Ireland and the stories that, but also the stories that I've heard from many, and even through the interviews that I've conducted. So the first thing is that when you think of a migrant, most of the time people always think of, people stuck somewhere in the Mediterranean Sea, a boat sinking. But a migrant is just basically a person who moved from one place to another, especially in order to find work or better living conditions. So in Ireland, just like what Daniel mentioned, is that they might include asylum seekers, international students like myself, migrant workers, those ones who are on critical skills and zero work permit, missionaries and dependents of all these that I've mentioned, and many other groups. So, but don't look at migrants as just as one category, not only students or maybe migrant workers, or it involves a lot of different categories. So when I narrow down to health, then health is normally one of the determinants of better living conditions. And this is one of the better living conditions that these migrant people are moving to seek in the new places. So whether you're moving from Ireland to Kenya, you have your own reasons of going to Kenya. You're moving from Kenya to Ireland, or you're moving from Kenya to Australia, you'll be a migrant. So one of the biggest dilemma that most migrants face the moment they land at Dublin airport, or with whatever means they arrive with, is the documentation dilemma. And this one, you can try to link it to access to health and how people access to health. So the visa says that you need to come here without recourse to public funds. What does it really mean to a migrant? Like, no recourse to public funds. Do I mean that I'm not supposed to benefit from anything? Then the permission says, like my own partner's permission and others, and even asylum seekers and other group of migrants, is that cannot work or engage in business. It's so aggressive on the documentation. Even when you apply for a job, you send that documentation and it's there, cannot work or engage in business. Even if you're qualified, will you get a job? Then you need a PPS number. So what is your reason for applying for a PPS number? Look, that is the question that will come from the PPS centers. You need to produce a letter maybe from the GP, you need to produce a letter from the creche, or you need to produce a letter from the school for you to get the PPS number, though you need the same PPS number to access the health services and other services. Healthcare, please contact your GP. When you go straight into some emergency departments, they'll tell you, oh, look, go and start from your GP. But do you even have a permanent address in Ireland when you arrive? You are living in a room somewhere in Dublin North or in Dublin South, and you're still finding your way. You're finding your way. You're negotiating with your landlord to include you on the bill so that you can produce it as a proof of address to get a PPS number or to get something else. How do you get these services? Health insurance for the students. You must have health insurance for you to renew your visa. Doesn't this just endorse the same narrative of without recourse to public funds? And how does this affect access to health? So the questions that come up when you think about this documentation dilemma among the migrants is that, does it mean that I have zero entitlement? Does it mean that when I'm sick, I cannot even avail for public health facility? Does it mean that even my child cannot avail for free or subsidized health services such as vaccination, etc.? Is this information even clear when you make a phone call to services? Yes. When you make a call and a human being is the one who will actually pick that call, they'll say, yeah, you can apply for a medical card. You can get free PrEP services. You can get free, sexual health services. But now when you go to the online form and the online form asks you, are you allowed to access public funds, or are you maybe on stamp 2 or stamp 3 or whatever stamp, all those permissions? When you click yes, then you do not qualify to continue navigating through the system. So the system blocks you, but the human beings tell you can. My worry is that, will this affect my visa? How? Is it worth risking? Is it worth risking to try to navigate free health services in Ireland? Yet I can just jump on a plane to go to Nairobi and not compromise on my future long-term visa goals. And when I do not have a PS number, what does it mean to you? So do you really need to have a clear justification to get a PPS number? Is this really necessary if the PPS number on itself is necessary for you to get these services? So when you arrive, the first thing that you meet is the cultural shock, and the cultural shock is mostly the systemic cultural shock. So just moving here, it's like it's a different health system from the system that you're used to. It's like starting a new school. You're coming from an English-speaking school, then you go to a German-speaking school or a Spanish school. You're scared of the new teachers. You're scared of the new schoolmates, the new language, and the new systems. So, and this has become even more challenging even during the COVID-19, because the GPs will be telling you, sorry, we are not taking in new patients. So some of us who moved in during the pandemic, did it mean that we could not access health? Did it mean that we had to find ways of seeking health? So the culture shock also comes from a behavioral perspective, from the individual himself or herself. I come from a community where we don't talk about sex. Could that really exclude me from accessing these services? You see, most of the sexual health services will have this eligibility criteria, like the PrEP services. I know you need to have engaged in certain number of sexual encounters. And even when I go there, could I fail to get some of the appropriate services because I might only report of a certain sexual risk, but I will not report about an STI that I have. Then also the influence of cultures that we come from, the culture that stamps heteronormativity. And this becomes a migrant dilemma. Like, do I even know whether, who I am? Do I even know my sexual orientation? I come with cultural beliefs that have been embedded in my system since I was born. So sexual health services are, and sexual health services here, like you see, like PrEP and some services that were mentioned here, mostly delivered in gay men health clinic. But even if I'm gay, I still live in communities, immigrant, small communities that still believe in heteronormal. So how do we make sure that within this pressure of remaining being heteronormal and not knowing who you are, how do we navigate through getting these services without barriers? So just looking at the data in November 2019 and just trying to look at the rates of HIV diagnosis by region of birth, you'll see that people who are born out of who are born abroad, most of them who are living here, actually they migrated to Ireland. The rates of HIV infection have been going up from 2011 upwards, and on the other side, you can as well see people who are born abroad. Also, the HIV diagnosis rate is also going up from 2011 to 2018, and I know maybe I did not get access to the data. This was the latest that I could. And when you look at HIV diagnosis among MSM by geographic origin, you can see also people who are born outside Ireland. The rates of HIV, they are going high. The new diagnosis numbers, they are going high. And this one basically could be because of what I have talked about. Like, you come from a culture that glorifies heteronormativity, and you arrive here, you're not so sure whether to access these services in a gay men clinic because you still maintain living within your communities. And when you try to come out, your community will ask you, what are you going there to do? But you're the only one who knows yourself. So what does that mean to all of us? Like, immigrants bear the biggest burden of HIV in Ireland. And whereas some will be affected with HIV, as you've seen, others could have other STIs and are having challenges accessing health services because of the definition issue. Then services, of course, need to expand beyond the gay men health services clinic to reach out more people at risk who may actually not have a clear definition of who they are. Because you're an immigrant, I am gay, but I cannot define myself as gay. So going to a gay clinic, services that are only offered in a gay clinic will only cause more stigma within my small community. And also just thinking of the more prevention options and prevention treatment services campaigns should expand to target more populations at risk, including the migrants. So thank you very much. And those are my contacts and the website of our project. Thank you.
Fernandes, thank you so much for yet another informative presentation. I think you brought up some really interesting issues for the audience there in relation to the kind of intersectional nature of some of the health issues that affect LGBT migrant populations. So thank you so much for that. I think we have a couple of minutes for questions. So I'm hoping Daniel, Bulilani and Fernandes are still all there. I think you are, yeah. Welcome back. There's one from Bill here that I think I'm going to direct, if it's okay, to perhaps Bulilani. Bill says, Ireland treats South Africa as a country in which there is a liberal regime for LGBT people. I think on the ground the experience is different. Is there anything that can be done to enhance the prospects of South African LGBT people accessing Ireland, asylum in Ireland?
Not in the activist community, there's nothing we can do, but there is quite a lot that is happening in the courts in that regard. So there were several South African, in general, Ireland treats South Africa as a safe country of origin, not just for LGBTQ plus people, but for all other asylum seekers from South Africa. We've had quite a few of them who have taken a judicial review of that designation of a safe country of origin. The court granted leave to bring judicial review proceedings against the Irish state because the court believed there is a case for them to answer as to why they decided that South Africa was a safe country of origin, especially in the context where there are 27 EU countries and only about 4 or 5 of them have that designation for South Africa. So what do the rest of the 22 who don't have South Africa as a safe country of origin see that is not seen by the island and others who have South Africa as a safe country of origin. So it's a very legal and technical issue that would need to be threshed out in the courts. We will wait for those judgments. One was due to be in January, but we just learned recently that the High Courts, because they are pressed with time, they've cancelled all immigration-related cases in the High Court. All the hearings that were scheduled, they will all have to wait until the end of October, I believe. So there's nothing, there's no movement in that regard when it comes to asylum and immigration issues, but it can only be fought in court. We can try to lobby the minister or campaign for the minister to do it, but in the past they have shown an unwillingness to change that. They also have other countries such as Georgia, for instance, and Albania on their list of safe countries of origin. Interestingly, the International Protection Appeals Tribunal has granted refugee status to several South Africans, South African women in particular, when there are same legal protections in South Africa for South African women. We even have a minister for women. We have a national day for women where all politicians make speeches about women's rights and the rest of it. But South African women experienced violence on a daily basis, and that's one of the reasons why the tribunal granted refugee status, because South African women couldn't rely on the police in South Africa to protect them, and that is actually their words. And it's the same for LGBTQ plus people, and so it's just a matter of fighting the legal battles. But we could try to persuade the minister to remove South Africa from the safe country of origin designation. I doubt it will work because they've demonstrated in the past that they are just not interested in that.
Folks, a question I have myself, if it's okay, to all of you, but I suppose following on, I suppose from Daniel talking about the need for research and Fernando's talking about the idea of taking services like the Gay Men's Health Service beyond its physical space. And I'm also thinking of a conference I heard you speaking at earlier in the year, Bulelani, when the question was posed about, well, what can we do as service providers to help in the LGBT arena or in the sexual health arena? And at that particular event, I think most migrants and some asylum seekers and refugees who were in attendance reported, accessing great supports from LGBT services. But I know for yourself, Bulelani, you really called it out in ways and kind of said that, more can be done. So I suppose I'd ask you and the other panelists, in reference to what you've already mentioned, for sexual health providers who are here today, is there any one thing you would suggest you could take away or an action to work on to improve access to supports?
I think Fernando's already spoke about this when it comes to people's sexual orientation and identities. It's difficult for people to access services when they are. There is a center, for instance, in Limerick. It's called GOSH, I think. A lot of LGBTQ plus people would be familiar with it in Limerick City Centre. But when an asylum seeker was asked in court, they were rejected. Their asylum claim was rejected. They were from Nigeria. It was rejected because the Irish government didn't believe that they are gay. And they were asked, why didn't you avail of supports from an LGBTQ plus organization? Have you been in contact with an LGBTQ plus organization? And he said, I know there is one. It's GOSH. But next to GOSH, it's where all the other African people shop and buy their food, their groceries, all the stores that sell products from African countries would go and buy this. So people from church, people from home country will see that there is an asylum seeker walking into that, and they'll be able to identify them. So for people who aren't out, it becomes difficult to access those particular services. Now, GOSH does go into the Drug Provision Center sometimes on their outreach, but again, when they go there, the only time I've ever seen them was for doing HIV testing. I go to the clinic regularly because wherever I always make sure that I will go. I'm on PrEP, so I always have to go to the clinic every 3 months anyway for my screenings. But there are people who aren't on PrEP who would love to access those services who cannot do so primarily because of one stigma within the community, because of accessing services that are tailored only for particular sexual identities. When you identify them by sexual orientation, then it becomes difficult for people to have to avail of those services. One thing that we can do is having an openness to that not everybody who identifies as gay will be comfortable to saying as gay. I think we all know that as gay people, but I don't think that message has sunk into service providers. My ex-boyfriend from Iran couldn't even say the word gay. Both in Limerick, in Ireland, our Prime Minister back then was Leo Varadkar, who is an openly gay man. Still, he couldn't say the word gay. So not everybody is comfortable with that identity, particularly in the context of where people come from, where they risk death if they do identify. And so it's not so easy for people to do so. There is a way we can reach people by communicating with people. I love the postal service, for instance, when it came to reaching people with condoms, that was introduced during the pandemic. That's something that we could easily maintain. There are ways, innovative ways of providing services to people in a way that doesn't out a person or that requires them to act themselves.
I think also maybe just a quick one. The first thing, thinking of my fieldwork experience, there's always one mistake that I always made as a researcher and also as a social scientist and a technical advisor working in the field. There's this thing that I believe in, that there's nothing for us without us. More often we design programs for others, thinking that it will work for them without involving them. So it's very important to have all these communities as stakeholders when you're designing programs, because not these programs, it's not a one shoe fit all. Everybody comes in different sizes, different shapes of those also know of morphology as a branch of different bodies types. People come in with different types of needs. And then when it comes to just also taking on my 3.5 experience in the field and issues around PrEP access and sexual health services access issues, is that more often we understand our own risks, and some of us may not be comfortable to talk about these risks, or I just know that I'm at risk, but I don't want to go into the details. So this is where the eligibility criteria of the several risk assessment forms that are there in the clinics need to be a bit like the providers need to compromise in some issues. Like I come and I'm indicating that I really need PrEP or I need PEP. So I know I have a wife and I have a 2-year-old. So the fact that I have a wife and I have a 2-year-old in the community, I'll be looked at as this heterosexual man. But I understand myself. Probably maybe I just married and I had this kid for the purpose of covering my face in my community. But I am the one who knows who I am. So services need to be designed in such a way that they don't exclude people who cannot confidently identify their risks through ticks and checkboxes. Thanks.
Thank you, Fernandez. Daniel, do you have anything to add before we wrap up, unfortunately?
Yeah, I'll just be very brief, because I think Fernandez and Bilani, you gave it the excellent points, and you've really been able to sort of highlight these issues. And I think the last thing I would just say, I know we're all here from the perspective of health, but I think what is clear here is that sometimes the greatest needs aren't health related at all. So I mean, it's just making sure that if they are able to access information about housing or employment, or just understanding what organizations are available to them, I think that's also helpful. So it's just knowing that sometimes when people are coming, they may have that opportunity to talk to you and talk about their needs, but you can also just see if there are other issues or other support that they may need to be guided towards as well. So thanks.
Brilliant, Daniel. Thank you so much. I'm just going to read out one final comment from Elisa Spindler, who I think raises a really interesting point that unfortunately we don't have time to go into, but she says that the Gay Project is very happy in response to their Proud as AF campaign, but we need to change real attitudes within the LGBT community too. I think that's a really important point. In the meantime, I want to thank Daniel Bulelani, particularly in the difficult circumstances of Zooming and joining us in from a library. Bulelani, thank you so much, and Fernandos for your really robust and interesting presentations, and an invitation to the Gay Health Network, I hope, to continue this conversation at a later date. And thank you everybody for your contributions.
Well, thank you very much, David. That was such an engaging set of presentations and discussion, and I think we could listen quite a bit longer to what the participants had to say. So really important sentiments there. My name is Stephen O'Hare. I am Executive Director with HIV Ireland, and I am delighted to be presenting the final session here at the Gay Health Forum this year. And it really is a pleasure for me to introduce our next speaker. Our final speaker for today is Professor Fiona Lyons, who, as many of you will know, of course, is Medical Director, Clinical Lead at the Sexual Health and Crisis Pregnancy Programme. That is a role that she has previously held between 2015 and 2018, and since the middle of September is back in post with our colleagues there. So that is fantastic to see and very welcome. Fiona, of course, is consultant in genitourinary and HIV medicine at the Guy Clinic in St. James's, and she has held that post since 2007. Interesting, no major landmarks approaching there, but she has worked in the area of STIs and HIV since 1993. So I can see in the distance something of a landmark date approaching. She won't thank me for that, but she does, of course, love being a doctor, and it's fantastic to have her here today speaking with us. She was also appointed as Clinical Professor of Medicine at the School of Medicine in Trinity College Dublin. So so we will get that lecture type approach today, I'm sure. Fiona, I really want to invite you now to present to the forum on your paper, which is titled "The State of the STI Nation." Thank you.
Thanks a million, Stephen, and thanks to everybody for the opportunity to present to you this morning. Unfortunately, I haven't been able to listen to all of the discussions, but I really enjoyed the discussion around that cultural competency language we use in the last session with Daniel, Bulelani and Fernandos. That was fantastic, and I'd love to hear more on that. And it's something I think that us in services really need to sit up and pay attention to ensure that people are interpreting the things that we say in the correct way, and we're imparting the questions to people in a way that is not offensive, judgy, and leaves them in a position to answer the question in an honest and open way with us. So I think I'm going to try and share my screen now and get on with the business of speaking to you about the state of the STI nation. So share screen. Okay, I think my screen should be shared with you now. Okay. So again, thanks a million for the opportunity to present to you today. So here we are, State of the Nation. This is Ireland, and I suppose I could, lots of people have spoken already before me about where we are with STIs. Naomi this morning around our surveillance information, and Caroline also spoke to us about the work we've done within the programme in recent past around trying to address sexual health needs across the country. So I suppose this graphic about syphilis I've used for a very long time, because syphilis came back when I was a reg in infectious diseases in the matter in 1999. It was the first case of early infectious syphilis I saw, and there's been no looking back since then. As you know, as Naomi alluded to earlier, we have an early infectious syphilis outbreak control team convened in response to a public health declared outbreak in June of this year. And I suppose what's different and what's important to note right now with the state of the nation in respect of syphilis is a couple of things. One is that in my experience, especially in the end of 2020 and the early part of 2021, is that people with syphilis coming into us have been sicker. I think this is probably a reflection of the fact that people have had access to testing challenges with the COVID-related restrictions, with the movement of people restrictions, and we were seeing people presenting through the emergency department quite unwell with secondary secondary systemic symptoms of secondary syphilis. And that's something that I would really like to see us being able to address as we move forward in opening up services, improving access to testing and improving awareness around risk. The second thing about syphilis that I think we really need to pay keen attention to is that we've had a significant increase in the number of cases reported in women. And as Naomi alluded to earlier on today, we have had some challenges with the timeliness of epidemiological information owing to the COVID situation and more laterally the cyber attack. But the fact that if it's going into women, then potentially the antenatal population is at risk. So we may end up seeing cases of congenital syphilis, which is something that we all work very hard to avoid. So that's there's sort of my sort of really big high level things in respect of syphilis and where we are right now. And the other thing is HIV. So this picture, I've taken a photograph. This is actually a structure of HIV, and Caroline gave this to me for one of my roundy birthdays a couple of years ago. I took a photograph of the picture that's up on my wall behind me here in the office. I would love to say that if you look at the weekly figures for HIV this year, there's a suggestion that there may be a turnaround in the number of new diagnoses. I appreciate completely that the robustness of our information with all the delays in reporting and stuff doesn't allow us to draw significant conclusions, but I would seriously hope that some of the reduction in the number of new cases reported in the year to date suggest that with things like PrEP, we actually are getting to the right people and we are averting instant HIV infections, which is what we all want to see happening. So, this is a glass of water. It's categorically a glass of water. I sent it to a friend yesterday and she said to me, "Is that gin?" I was like, "It's categorically water." Okay, folks. So I tend to take my approach to life tends to be one of having a glass half full rather than one half empty. But we are 18 months into a very, very challenging time internationally and in every which way. We've all had a bit of a hard time the last 18 months with the pandemic. And so I'd like to acknowledge some of the things that may make us look at the glass as being half empty, and then focus in my usual way on how the glass may be half full and hopefully getting fuller as we go on. So as I said, we're all a bit battered and bruised with 18 months of living with the very unwelcome visitor to our shores that is COVID-19. For those of us working in healthcare, we had a further very significant health back with the cyber attack, which really kicked us when we were down. All of this has led to very significant service impacts, surveillance impacts. We knew we had a problem with syphilis before the pandemic, and this problem is ongoing, and it has been a challenge trying to address this problem in the context of restricted access to services, restricted access to surveillance information. And the other thing, I suppose, is that we have to acknowledge that despite the fact we've managed to roll out PrEP, there have been teething problems which need to be addressed around processes and access for individuals who may need and benefit from being on PrEP. So, moving to the half full and beyond situation, hopefully we're over the worst of the pandemic. Zoom, Teams, WhatsApp, and Silo, which is a confidential service that can be used by healthcare professionals, absolutely saved our bacon in the last 18 months. I think that we wouldn't have been able to manage if we didn't have Zoom for family, for meetings, for all sorts of things. Teams was the other one we were using, and WhatsApp was very useful because sometimes Zoom and Teams wouldn't work at all, and we could have meetings with WhatsApp video calling. I think there's no doubt that we all learned new ways of working and new ways of interacting. And I think there are efficiencies that we can identify there that we can bring forward to us as we try to get this state of the nation with respect to STIs to a position of being more than half full, the glass being more than half full. But there's no doubt it is so good to interact person to person again. And I really hope the Gay Health Forum can be held in a face-to-face setting next year, which would be great to see all of you again. So moving on to more than half full, Caroline alluded to the online STI testing pilot that in spite of COVID, we sought to get the funding and we managed to secure the funding to roll out a pilot. I think that in order to have access to STI testing and HIV testing that meets everybody's needs, we need to have a kind of a jigsaw puzzle of different ways of delivering that. And having the online platform is something that is very important for some people who would never seek to come forward to services. And I think that's been reflected in the fact that over half of the individuals who availed of the online STI testing in the pilot phase had never accessed STI testing before. The other thing is that it allows us within services for people who are able to navigate systems and health systems and do get into our face-to-face services, but may not have very complex needs. Those people can be moved out into a less complex situation, giving us more time to look after those who are more vulnerable or who have more complex medical needs. So hopefully, with Budget 2022 will come funding for us to move beyond the pilot phase of the STI testing into national rollout in 2022. We have been fortunate in respect of the infectious syphilis outbreak that we have been afforded the opportunity to continue with testing and extend testing into additional counties beyond the pilot phase to ensure that we've got ongoing access to testing and creating capacity for syphilis testing with the outbreak. I have to say, working in the PrEP service in the Guide Clinic in James's and watching my colleagues around the country and watching colleagues in clinical services, in the programme, in PCRS, community colleagues, everybody worked so hard to ensure that the individuals who were on PrEP and who had managed to get engaged with PrEP before the pandemic struck, that we had rapid flexing of how we deliver our services to ensure that PrEP was continued. I was thinking about my talk last night and I'm going through the slides in my head, and I remember I was in a COVID planning meeting with a number of other people in a huge room, all of us spaced out 1,000,000 miles from each other, wearing masks, planning when we were going to open the next COVID ward in James's, and my phone rang and it was somebody from PCRS saying, listen, we're just going to roll over everybody's eligibility because we don't know what's going to happen in the next couple of weeks. And it was just literally we made decisions very quickly to try and ensure that people had continued access to their PrEP. I appreciate that it wasn't perfect, but I think everybody who was involved in that needs to be given a significant pat on the back because it wasn't easy. And I think the things we learned about how we can deliver PrEP will have allowed us to build further efficiencies. We don't necessarily need to see people face to face for all of their visits, and then we can do this in a telephone way or another e-health way to improve efficiency, create further capacity so that we can see more people and see more vulnerable people who may need greater time in the face-to-face setting. We had a pop-up syphilis testing hosted in Hpv Ireland. Thanks a million, Stephen and colleagues, for that in July, where we ran 3 evenings. And the glass, in respect of passion for what we do in a multisectoral way, is absolutely overflowing. We all had great fun on these nights, and we managed to test a significant number of individuals for syphilis and HIV. People gave freely of their time. They got a pizza. But that was about it. But they worked for 3 hours in an evening over 3 Thursday evenings in July, and we had great fun, and it was really good. And I think that this is something that has always been one of the things that I took away from being clinical lead last time. Is what I loved most was the teamwork, the multisectoral teamwork, and that is categorically what makes progress and what we need to bring with us moving forward. So I'm delighted that the passion for doing what we do is still very much alive. And you can see 2 of the ladies here from Portlaoise, up here, I'm not sure if my pointer's working, had got t-shirts made for the event. The other thing that I think is great is that with applying, with some phone calls and some discussions, we were able to ensure that collectively ensure that HIV and STI surveillance was reprioritized, such that the team of Naomi and colleagues in public health and HPSC were able to get back onto the job of looking at HIV and STI surveillance. Everything had been taken over by COVID, and everybody was really concerned about our surveillance with respect to HIV and STIs. And so we all collectively put on pressure and got people back into HIV and STI surveillance, and then very quickly quickly Public Health convened an outbreak control team, which again has the multi-sectoral working, and hopefully we'll manage to turn things around with respect to the number of new cases of early infectious syphilis. We're more than half full in respect of having the clinical team. This is Rachel and Caroline and myself in the boardroom yesterday, getting our slides ready for today. And it is so great to be back and part of the clinical team. I think we have loads of work to do. The cupboard of work opens a little bit more every day I'm in here, and a little bit more falls out. I'm kind of, gosh, there's just so much to be done. But with such a fantastic team, I have no doubt that we'll do great work together. I really want to commend Caroline, who carried the clinical team on her own for so long when there was no clinical lead, and before Rachel joined the team. I think you deserve enormous praise and gratitude, Caroline, from everybody for all the work that you did, and thank you for that. So, we have a problem with syphilis, there's no doubt about that. We still have a problem with registration and access to PrEP, there's no doubt about that. We still have challenges with our surveillance information, but we have a glass that's getting fuller by the minute. We have our clinical team back together here in the programme. We have proven that we still have the passion to work together in a multi-sectoral way. So I think that while we may be in a bit of a tricky situation now in respect of STIs, that the only way is up. And I really look forward to working together with all of you in 2022 to improve the sexual health of the nation. And again, to thank you all for the opportunity to present to you here today. And I hope that what my few words were of value to you. Thank you.
Thank you so much, Fiona. That was wonderful. It strikes me, you're absolutely correct. The commitment of staff, particularly in the last 18 months, has been it's unquestionable, and it's been fantastic across the board with the clinics and organisations that we engage with and who provide services. And I'm also struck, as I always am, by the commitment of people who volunteer time. And this sector, in this particular community, I think the spirit of volunteerism is really, really high. And that doesn't absolve us from ensuring that the services are in place to meet the needs that people have. But it is really heartening to see people come out and shoulder the burden when something like a syphilis outbreak occurs, when we are in a situation of a public emergency, with such as COVID, and put their shoulders to the wheel and move things on. So it's fantastic, and I would say well done to everybody on that regard. I have a couple of questions, if you don't mind, because if that's all right, because I get to go first. So let me ask you a question around the COVID issue. I think it's a question that's on people's minds. What must happen now structurally, in your opinion? And I'm not trying to nail it to any commitments. So what must happen to ensure that when we face this type of challenge again, if we face this type of challenge again, and hopefully we won't, a public health emergency of this scale, what do we need to put in place structurally to ensure that the services like the testing, the access to clinic, it remains in place for people in the way that continues our mission to tackle these other issues, these STIs that are in our community? What can and should we do or think about doing?
Well, I think that we've learned a huge amount about what we can do. So hopefully we'll get the funding to secure the online STI testing platform, because that was something that doesn't require individuals to leave their home. I think if there are public health recommendations around movement of individuals, then there's very little we can do about that. If the greater risk is that we should be at home and not interacting with anybody, then we have to respect that. We've all flexed how we do things. Telephone conversations. I had my physiotherapy appointments I'd get a link on my smartphone, and then I'd follow it, and I'd have my physiotherapist be standing in front of me on my phone. So I think we've all learned different ways of doing things. And I've been really amazed at the resilience of people and the adaptability of people. We got things done in the last 18 months that would have otherwise taken 5 to 10 years. So I think if this ever happened again, and I hope it never would happen again on the scale that it did, that we would document somewhere the learnings that we've done, so that we can open that book up again and have an emergency response in place. I think we've all filed them in our heads. Very quickly within our service, for our HIV service, we very rapidly made sure we had ongoing supply of medication for people to ensure there was no break in supply. But there was no way we were caring for people the way we wanted to, but we had very little choice. It was very, very challenging. So to directly ask your question, I think we probably need to catalogue the things that we did in response and critique them to see what was good and what was bad, and then decide what we should potentially bring forward. But I think one of the big things that would help if we were in such circumstances again would be availability of online STI and HIV testing.
Absolutely, and it's so welcome to see that roll out so successfully. My last question, and of course I know people are pressed for time, I will ask one last question, and it behooves me to ask a question about HIV, just given my role and the opportunity to question you about it. If I was to invite you back, and given you are a glass half full person, if I was to invite you back in 2030 to give a follow-up state of the STI nation, why do you think we will have been successful in ending new HIV transmission by that date?
So where we have a glass full, Stephen, and we're assuming we have reached that, yeah?
I'm saying that when we get to 2030, we'll have done it. Why do you think we'll have been successful in doing it? You tell us.
Why will we have done it?
Yes.
The first thing that strikes me is that we've been working together. That's I think one of the most enjoyable aspects of being clinical lead between 2015 and 2018 was the learning together. I in my job in James's in 2007, I had to set up a service in prison, a prison in-reach service, and what I learned really, really quickly doing that was the value of peer learning and peer support, and within the prison setting. So the one thing I would say is, if we've achieved it because we're working together, categorically. That's the one thing I would say.
Fantastic. There is one question that did just pop up, and I might just throw it in here at the end because it has come in from the audience. And Bill has asked, just in relation to PrEP, is there evidence or consideration for a change in the criteria for new entry to the PrEP program? So the current assumption would be that men taking PrEP take PrEP daily long term, but in reality they may only need it for periods of heightened sexual activity or for holidays, particularly sex holiday destinations. So is that something that could be considered in terms of criteria revision?
Yeah, it is being considered at the moment. Yeah, it is, absolutely. And you're right, there is a definite, I suppose, when you've got to make an economic argument for a new health intervention, you need to kind of you need to demonstrate economic value, and that's how health systems run. And so identifying people who may be at a substantial risk of HIV on past behaviour is what guided the eligibility criteria for the current guidelines. But we definitely need to consider future risk. And it is responsible and proactive of an individual just as well to say pack away some condoms when they're going on holidays as potentially to pack away some PrEP. So yes, there is consideration being given to that. I can't make any promises about it, but there is, and that is, I think that's an international shift as well. There's an international shift to recognising potential and anticipated risk. And I think it was Fernandez who reported that somebody will know when they need PrEP. And I agree with that statement. But I would say that in my practice, I see lots of people who don't know when they need PrEP. And so I wouldn't say it's universally true, but there are a significant number of people who will know when they need HIV prevention, STI prevention, i.e. condoms and PrEP.
Well, that was a great question, and that's a great answer. So thank you very much for that. Thank you, Professor Lyons, for that such an engaging talk and such an engaging presentation. I need now to sort of move our conference today. So I would just like to really offer some thanks before I let you all go and have your lunch, and that is to say thank you very much, of course, to Minister Frank Feehan for opening the event and for his contribution. I also want, of course, to thank our many contributors and presenters and hosts today for their very, very engaging and enlightening presentations, and for really good discussion and the work that they put in preparing for today's event. As always, we have to thank our colleagues at GCN for their expert hosting and delivering of this event, and particularly to Alice for her technical expertise for keeping the show absolutely on the road without a hitch. That was fantastic. I want to pay tribute, if I can, to the Gay Health Network, to the constituent members of the network who all continue to invest in improving health and well-being outcomes across our constituency, and it's very important to recognise that. And I want to say a special and well-earned thanks to the organisers of the event today. That is to our colleague Bill Foley and Jason Doyle at the Gay Health Network, and my colleague Adam Shanley, the Empower Programme Manager here at HIV Ireland. I think everybody can agree this was really a really excellent event today, and something that was very worthwhile and will give a lot of food for thought. We are at HIV Ireland delighted to have partnered with the Gay Health Network to ensure that the forum could take place this year, albeit in an online format that we are all used to. But I know that everybody is really looking forward, and we will be very much looking forward to getting back to delivering such an event in 2022 in person, to see you all, to shake your hands, and to have a coffee afterwards. Finally, I want to thank all of you who stuck with us today, our viewers, for attending our event and engaging with questions and comments. It's very much appreciated, and I think really that's everything we have today. So I wish you all a very good afternoon.